and mucopurulent discharge associated with fatigue, reduced appetite, and the appearance of erythematous scaly lesions on the buttocks. The past medical history was just positive for atopic dermatitis with periocular involvement. In addition to the eyelid involvement, he presented punctate keratopathy Oxford grade 3, while the fundus was unremarkable. So we performed a conjunctival and exfoliated skin swab and initiated a general treatment with intravenous hydration and nafcillin in 4 divided doses associated with an ocular treatment with fusidic acid and hypochlorous acid spray. The patient was then referred to the pediatric department for further investigation. In the first day, he developed a positive Nikolsky signs with fever, a bilateral periocular involvement, and generalized desquamation with leukocytosis. On day 3, the culture test resulted positive for Staphylococcus aureus producing exfoliated toxin B, and so Staphylococcus cabri skin syndrome was diagnosed. The systemic therapy was switched to intravenous clindamycin. And we can see that after 6 days of therapy, we had a complete resolution of the eyelid inflammation and extraocular skin lesions with a negative blood culture. And the patient was discharged on the 80th day with a 6-day course of oral cefalexin associated with topical treatment. The second case is a 38-month-old boy that presented with painful erythematous blistering lesions involving the face, neck, trunk, and buttocks associated with low-grade fever. The past medical history was negative, and the ocular examination he had bilateral eyelid edema and erythema with evident desquamation. However, in this case, the corneal flow test was negative. So microbiological cultures were obtained from skin, conjunctiva, nasopharynx, and external iotano. And treatment was initiated with intravenous teicoplanin hydration with the topical fusidic acid and hypochlorous acid spray. Within 48 hours, the fever resolved, and we had a marked improvement of the local and systemic manifestation. The culture resulted positive for methicillin-resistant Staphylococcus aureus, and the antibiogram revealed a susceptibility to both teicoplanin and fusidic acid, so this supported the continuation of the current systemic and topical regimen. After 6 days, we have the normalization of the white blood count and resolution of the cutaneous manifestation. The Staphylococcus cabri skin syndrome is a rare but potentially life-threatening exfoliative dermatosis caused by the exfoliated toxin AB of Staphylococcus aureus that cleave the hemoglobin 1 obstructing the keratocyte adhesion and causing a superficial epithelial detachment. Is clinically characterized by erythema, blistering, desquamation, and positive Nikolsky signs. However, ocular manifestations are uncommon and poorly documented in the literature. But the ocular amnesia may be particularly susceptible to this toxin because the hemoglobin 1 is highly expressed in the superficial epidermis of eyelid and the periocular skin, and this associated to the relative paucity of compensative hemoglobin 3 and mechanisms such as blinking, wrapping, monitoring the bacterial colonization may further enhance the toxin-mediated epithelial fragility and contribute to the early periocular manifestation of this syndrome. So in conclusion, these 2 pediatric cases illustrate that ocular involvement in this disease, although uncommon, can be an early and clinical relevant manifestation. In rare instances, such as our first case, the staphylococcal blepharitis and keratitis may serve as an initiating site of infection, with subsequent evolution into a full-blown disease. And early ophthalmological examination was pivotal in both cases, enabling an accurate diagnosis and prompt initiation of a targeted therapy. And this underscores the critical role of ophthalmologists in recognizing a dermatologic emergency in a picture of multidisciplinary care. Thank you for your attention.
Please, the second one, Chirita from Romania. but also be prepared to rise up to the next column. Yes, please.
Good morning, my name is Carmen Chirița, I'm from Romania, Bucharest, and today I'm going to present masculine fungal keratitis, Mycobacterium abscessus presenting with a perfect fungal phenotype. We have a female, 38 years old, wearer of night and day contact lenses, with a history of superficial keratitis with unfavorable evolution for 1 month under empirical treatment with levofloxacin, metilmycin, and dexamethasone. At the last checkup, ocular hypertonia was observed and it was treated as herpetic keratoiditis with further unfavorable evolution, and so she was admitted to the hospital on 29 November 2024. The best corrected visual acuity of the left eye was hand motion with an intraocular pressure of 30. We can see a superficial upper paracentral ulcer with retrocorneal precipitate and hypopyon. We ran some diagnostic tests. Culture from the conjunctival secretion was negative. Also, the corneal scraping was negative. Although mycobacterial growth was observed, it was interpreted as environmental contamination. We also performed in vivo confocal microscopy, where we saw hyperreflective white dots of approximately 4 microns in the basal layer of the epithelium. In this moment, we excluded acanthamoeba and filamentous fungi. The differential diagnosis with a lot of types of keratitis, the fungal one, because she has a long evolution associated with contact lens wear and hypertonia, but the culture was negative. For the viral one, we had hypertonia, but the cyclovertebrotic test was negative. For the parasitic one, we had a painful superficial lesion associated with contact lens wear, but we had hypertonia. For the bacterial one, we excluded this cause because of the negative culture, the negative therapeutic trial with levofloxacin and metilmycin. We excluded also the autoimmune inflammatory keratitis because of the anterior chamber involvement related to keratitis. And we also excluded the sterile keratitis because of the continued progression despite stopping the contact lens wear. So at this moment, based on everything we did, and mostly on the clinical appearance, the positive diagnosis was infectious fungal keratitis associated with contact lens wear and secondary anterior uveitis. The evolution was favorable on the topical treatment with voriconazole and amphotericin B and intravenous fluconazole, so we discharged the patient with voriconazole, oral and drops, metilmycin and dexamethasone, and dorzolamide, timolol, and acetazolamide to lower the intraocular pressure. On 16 December 2024, she came back with a new infiltrate with invasion towards the limbus and hypopyon. We performed again the confocal microscopy where we saw multiple cysts suggestive of yeast fungal infection. On 20 December, she developed endothelial plaque. On the anterior segment OCT, we can see the endothelial plaque, the infiltrate, and the ulcer. Okay. So we decided to perform intrastromal and intracameral injection with amphotericin B and aspiration of the retrocorneal infiltrative masses. She came back on 7 January with the 2 initial lesions and hypopyon, and the evolution was getting worse and worse, so we decided again to clean the anterior chamber and inject amphotericin B, intracameral and intrastromal. On 11th March, we decided to perform therapeutic penetrating keratoplasty, and the postoperative treatment was also with amphotericin B, levofloxacin, metilmycin, and dexamethasone. The definition of the cornea, we tried to clean a little bit the anterior chamber and then place and suture the corneal graft. We sent the cornea to the lab, and with the help of multi-top mass spectrometry and chocolate agar culture medium, the Mycobacterium abscessus was identified. This is a multi-drug resistant, rapidly growing non-tuberculous mycobacteria present in soil and water. These kind of typical infections are rare and often difficult to identify due to low clinical index of suspicion, delayed laboratory identification, use of corticosteroids or broad-spectrum antibiotics. It can form biofilms, which makes infections more resistant to antibiotics and more persistent, leading to chronic inflammation. This is the aspect post-operative. We can see some posterior synechia and cataract. The prognosis on long term is good. We managed the cataract on March 2026. We also managed the residual astigmatic secondary to corneal sutures in April. With suture lysis using topographic maps, 0.6. The case is particular because it was an infectious keratitis with an atypical, rare, and difficult to detect germ. The partial response to amphotericin B delayed the diagnosis, and we still don't know why it was partially effective, but study says that the amphotericin B reduces the fluidity of the cell of Mycobacterium abscessus and penetrates it, but the rest of the effects are not proven. And biology, my team, thank you so much for them. And thank you for your attention.
Now the next speaker is Che Jung, Globe, Savage, and Visual Rehabilitation of Severe Facial Polytoxic Keratitis. Please.
Have my slides? I'm Albert Chung. Thank you for having me. Could you add up the slides there? Perfect. I have consulted for Brightstar Therapeutics, otherwise I have no other relevant financial disclosures. Presented a case of lobe salvage and visual rehabilitation following a severe case of polytoxin keratitis. This involved a 42-year-old man who presented with 4 weeks of redness and irritation to his right eye after working in a saltwater aquarium the night before. He was otherwise healthy, had been started by an outside provider with topical antibiotics, topical corticosteroids, and oral corticosteroids for possible toxic keratitis, as the coral he had been working with was known to secrete polytoxin. He was referred to us after significant worsening. Here you can see the vision was counted fingers, severe thinning with keratolysis, as well as infiltrate and a large epithelial defect. Despite aggressive management, unfortunately, he perforated on day 6. And so we performed a therapeutic penetrating keratoplasty. Initially, the vision had improved, but over the ensuing days and weeks, vision started to worsen. On the host side, you can see the infiltrate that started, and this, with the overlying epithelial defect, this progressed onto the donor aspect of the graft as well. Culture was negative, and so we presumed that there was some polytoxin that was retained in the host side. There was no response to amniotic membrane, tarsorrhaphy, and there was increasing inflammation with concern of opening of the graft-host junction. So we performed a wound revision with amniotic membrane and tarsorrhaphy. This helped briefly, but then it recurred again. So a more definitive approach was for a globe salvage procedure with a Gunderson flap. So this was successful in quieting the eye and stabilizing it. And so we left this for nearly 3 years. But a young guy, he could have a course of synedromin. But a young patient was only achieving about 2200 to 2400 visual acuity. We wanted to see if we could rehabilitate the vision further. And so I had concern if I just took down the flap that with the severe neurotrophic keratopathy, as well as likely loss of stem cells from iatrogenic, from the flap, as well as a large PK, and then also polytoxin is known to cause a limbal stem cell deficiency, that he would have trouble epithelializing. And so looked at the literature and combined a few techniques. The first is using a Descemet's membrane anterior keratoplasty, which uses Descemet's membrane on the anterior aspect of it as a substrate to anchor new epithelial cells. Because this does express limbal basement membrane proteins on its anterior aspect. It does not provide stem cells though. And so in the past, I've used for sectoral partial limbal stem cell deficiency, just using segments of keratolimbal allografts. So these mini KLAL segments are able to, you can see in the picture on the right, the late staining superiorly, but it just put in a segment of the stem cells in that area without the rest of the keratolimbal allograft tissue, and is able to provide stem cells enough to provide corneal epithelium. But what happened if we were able to make a surrogate limbus out of these small segments, as they did with this oral mucosal grafts, in this case of Amit with amniotic membrane, and in a case of total limbal stem cell deficiency. So that was our goal here. So here's a video of the case where we have our conjunctival flap, use epinephrine, a partial trephination, and a stromal dissector to peel off the flap. This is about 6 millimeters. Once this is excised, we'll smooth the surface with a keratectomy and a diamond burr. And then we have pre-stripped tissue and punch this with a 5 millimeter punch. And then we remove the anterior cap, leave descendants membrane on the surface. This is smoothed out with a cannula. It's allowed to dry. You can see the S stand for orientation. And here it's just isolating the palisades of wood. Crescent blade to groove on either side of it, and then band of scissors to excise these strips. These are placed at the surrogate limbus around the edges. Tissue glue to secure the tissue, these segments. We place the amniotic membrane on top, and then a large diameter contour lens, contact lens, and a suture tarsorrhaphy. This is what the patient looked like post-operatively. He was also on topical corticosteroids, antibiotic, cyclosporine, sodium chloride, and synedramine. Orally, because of the keratodermal allograft segments, he was on oral mycophenolate as well as a tapering dose of oral prednisone. Early post-operatively, we did lose some mini KLL segments supranasally, but he was able to epithelialize this in about a couple weeks. You can see a little pooling, but you can see the new corneal epithelium growing in and had some improved vision. And this is him nearly about 2 years follow-up where the vision has improved to about 20/50 to 20/80. With the scleral contact lens, he was able to achieve 20/25. You can still see the vessels from the peripheral venous flap that we had left behind, but those vessels have also decreased. There's some mild central corneal haze, but the patient has remained with no epithelial defects during the follow-up. There's a little bit of late staining in the supranasal area aspect where we lost some segments, but the rest of the central cornea has good corneal epithelium. So thanks for allowing us to present this difficult case and how we rehabilitated it. Thanks so much for your attention.
Good morning, everyone. My name is Adam Cohen. I'm here to present a case on a vasculitis case. Perfect. So this is going to be eyes before systemic signs, an unusual case of an 11-year precursor to ankylosing. So jumping in straight to the presentation here, we saw a patient who was a 71-year-old male who presented for tearing, eye redness, and blurry vision, more so in his left eye than right. He had no significant past medical history, no surgeries, no trauma. And when we did a slit lamp examination, what we could see is that there was moderate pannus on his eyes bilaterally, more so on the left eye. And because this is kind of a weird presentation, we did a review of symptoms, but nothing came up. Still, due to this kind of strange presentation, we gave him a systemic workup, and we saw that he had a few elevated markers, specifically CRP, P-ANCA, and ESR. Unfortunately, he was lost for follow-up until 8 years later, and he returned looking like this. In that time, his symptoms had continued to worsen. He had more eye redness and a burning sensation in both eyes. And when we looked at his eyes again, we could see that the pannus had grown in both eyes. Specifically in the right eye, where it started to impinge on the visual axis, where his visual acuity decreased from 20/20 down to 20/40. He was lost for follow-up again until 3 years later, so this is now 11 years since his initial presentation, and he came in again because of decreased visual acuity. When we looked at his eyes again, the pannus had continued to grow, and this time we saw more significant decreases in his visual acuity. His right eye decreased from 20/40 down to 20/60, and his left eye went from 20/20 down to 20/25. And at this point, which may be spoiled a little bit by the title, we saw some systemic symptoms come up, specifically involvement in the lung and the kidney. And at this point, finally, he was able to get onto immunosuppressive therapy that he was able to stay on consistently. So just to give a little bit of a background on what we tend to expect for vasculitis, the ankylosing are a group of diseases that look at middle, or like moderate and small vessel damage. They include things like microscopic polyangiitis, granulomatosis of polyangiitis, and the really long eosinophilic granulomatosis is called angiitis. Typically, they involve organs like the lungs, upper sinus tracts, kidneys, skin, and nervous system, although 16 to 23% of the time, they involve the eyes. And when they do, they tend to, you tend to see scleritis, but you can also see episcleritis, orbital inflammation, as well as peripheral ulcerative keratitis. In our case, what we saw is that 11 years after, the systemic symptoms that he presented with was lung infiltration with a persistent cough, infection into the kidneys with proteinuria and hematuria, and then when we did a chest CT, we saw that there was interstitial opacities, pleural thickening, atelectasis, as well as a calcified granuloma. Our management of this disease was rituximab infusions, methotrexate, and then continued topical steroids. However, due to the significance of the pannus on the right eye, he did require surgery to reduce it, and I have a picture of it right here, which looks a lot happier than he was beforehand. And so the discussion and the key points to take away from this are that P. ankylvasculitides can be severe with ocular manifestations that precede any other sort of systemic symptoms. An atypical corneal pannus can be an early sign of systemic vasculitis. And if there's consistent inflammation, it should be a cue to you guys to give it an extra thought, think that there may be something deeper going on here. And then finally, long-term monitoring and adherence to therapy is essential, along with early intervention. If our patient had gotten this, likely he wouldn't have had as severe manifestations and his visual acuity would have stayed improved. And with that, I just want to thank SICSSO and my team for all the help.
About you? Until the
Good morning, thank you for your kind invitation. And today I'll talk about this case of anterior uveitis associated with hypervitaminosis related band keratopathy in a 48-year-old male who is a gym addicted, so he had these massive doses of vitamin D self-prescribed. And then he had these high blood calcium levels that caused him also a chronic kidney disease and this bone resorption that causes him this complex regional pain syndrome. Then he started treatment with benhydronic acid, Enrica, and presented to our department 3 days after the start of the treatment with bone pain, fever, and mild ocular symptoms with this band keratopathy. Then we dismissed him, advising him to consult a rheumatologist, but he never did. Spoiler. And then he came back 4 days later with these acute symptoms with flare cellularity, a decreased visual loss and epiphora. So we started treatment with steroids and cycloventilate because he also started to have this posterior synec in the left eye. This is the kind of angry eye of the patient, the right eye, and this is the left one. Then we gave him an appointment for 3 days later when the symptoms started improving, but you can find this synec in both eyes that mark the pupil. Also, cellularity and flare start growth. Arise. This is the pupil of the patient. Nearly 10 days later, he started improving better, but he had this deposition on the anterior capsule of the crystalline lens, and then after almost 4 months, he started to get back to his starting condition, but this limbal keratopathy, perilimbal keratopathy remained. Also, this pigment, we can find this in the photographs, but also in the anterior segment OCTs, we can find these depositions. All the time we told him to consult the rheumatologist, but he never did because he didn't believe a lot in medicine. For all time, the fundus examination was absolutely unremarkable, as was the posterior segment OCTs of the macula and optic nerve. Also, the ultrasound was negative. The vitreous was clear. He had no problems. So we assessed him. We treated him like an anterior uveitis. What do we know? We don't have many articles about neridronic acid, but we have solid literature about ocular adverse event of biphosphonates. They cause symptoms like conjunctivitis, scleritis, episcleritis, or anterior uveitis, like this case. But we should always assess for a patient with these symptoms through medical history. Thank you.
I just wanted you to look at the top of your slide. If you can show back one of your slides.
Yeah, sure, also.
Your header is late onset focal stromal degeneration after collagen process.
Yes.
That is what is the head. But your whole talk was on vitamin or
Yeah, because I stand in for a colleague of mine who apologized but cannot be here today, so I'll have another one. There are two. This is either vitamin C related band keratopathy, and then there's one about focal stromal degeneration.
But both of them have the same title. Never mind.
I'm so sorry. I don't know what happened. I'm so sorry.
We've got some time for discussion. So we had some very good cases. I just want to have a question to Dr. Chun about the excellent case of the multiple approaches to salvage the cornea. You seem to have not done anything about the blood vessels, although you had a Gunderson flap with a lot of blood vessels, but you did limbal transplantation, cornea transplant, all the rest, but a lot of mature vessels. So the risk of rejection would have been quite high. Did you do something about them?
We did not. Sometimes we use mice or mitomycin intra-arterial care and do hemoembolization, but I didn't want to introduce any mitomycin just because of stem cell deficiency. In those cases, we could try argon, but I thought that in using the DMAC in the past, the descendants membrane seems to be a barrier to vessel growth onto the cornea. So that seemed to be enough, at least in this case. That with the stem cells, as long as we were able to provide that limbus, it seemed to be enough as a barrier.
It's not, because we also used to say amniotic membrane is a barrier. It never really is in every case. The biology of the vascularization is very different, and there are other means of just a point to know that the biology of vascularization overcomes all these barriers if the stimulus is aggressive enough.
The one thing about, they've shown that the descendant membrane compared to amniotic membrane will persist much longer though, because amniotic membrane will obviously dissolve. But descendant membrane, even years out, it'll persist on the surface. So I think it might have a little different biology.
Thank you.
I have a question, Dr. Trivita. Ask your questions, we'll come to the microphone. All right, during your surgery, what was your approach? Did you give some sort of antifungal, antibiotic, any type of treatment during surgery, wash out the anterior chamber? Was there something administered during the surgery?
After the surgery.
During the surgery?
No.
No.
But after the surgery, we injected
Pardon?
injected in the camera after the surgery.
I'm sorry.
After the surgery,
Yes.
We injected them with LCD.
You didn't do any type of particular washout or culture at the time.
We did.
You did.
So we did many time points during the course of the disease. We injected after tempi at this end. Right. And then during surgery, of course, we washed out and did the same. It was the only thing that.
So when it was open sky, you did some sort of.
Of course. Also on the edges of the trepidation.
I have another question for you. Why did you say increased pressure is a con for parasitic infection? In your table, you said hypertony is a negative for acanthamoeba keratitis. Actually, I find it the other way around. You get a lot of instances where you get raised pressure with acanthamoeba and also sudden onset cataract, and sometimes the two are together. So I wouldn't take it as a con for the diagnosis of acanthamoeba.
You did not consider performing a corneal biopsy when you did not have a definitive diagnosis. Do you think that that could have helped you arrive at a diagnosis before you did so many intrastromal injections and other things?
We actually suggested this to the patient. We actually suggested the biopsy. It would have been our first ever biopsy for an infectious type of disease. She actually wanted to go straight to PK at that point.
And if you suspect fungal keratitis, is it common to combine antifungals with steroids as well? Because I saw in your post-op regime and pre-op as well that you were giving steroids along with the antifungals, because we know that that can be counterproductive if you give steroids.
At that point when we saw that it was out of scope.
I think the presenter has to answer the questions. I'm just kidding. Well, the question, you got off because he answered the question.
A question to Dr. Troisi about the incidence of the skin syndrome.
Thank you for this question. The syndrome is extremely rare. It has an incidence of 0.09 to 0.59 cases per million. And these were the first two cases published in literature with an early manifestation in the periocular area, also with an ocular surface involvement. So this is novelty. Okay.
I think only one of the presenters has been left without a question. So in that, which was that one, your eyes before systemic signs, you had 2 periods where the patient had been lost to follow-up. But your very first presentation of the patient, you had raised ESR, raised CRP, and P anchor positive. So why was systemic immunosuppression not initiated right at first presentation?
Can everyone hear me? Yes. Okay, perfect. So at the beginning, when we saw the elevated P anchor ESR, that was like a sign that there was an inflammatory disease going on. And so initially he was going to be treated with methotrexate and then chlormethalone. However, before he could take a consistent regimen, that's when he left and he didn't follow up, and he wasn't on the medications after that. So he was started on the medications, but he just didn't have consistent treatment within those 11 years until he came in with the systemic symptoms.
And sort of you would then eventually you would think of vagus type of polyvasculitis, is it?
It's like a little bit of a muddled picture. We were thinking either like microscopic or eosinophilic due to the P anchor and not C anchor. However, because there was a granuloma that's more inconsistent with microscopic, though it still also didn't fit a perfect eosinophilic picture either. We felt confident that it was an ankylosing, but in terms of how narrowing down the diagnosis to one of them, it was a little bit more difficult because the picture didn't. It wasn't a textbook example.
Thank you.
Just one question to Albert. What was the status of the fellow eye of that patient? Was it normal?
It was normal.
Then why you didn't consider doing a conjunctival autograph, limbal autograph compared to doing an allograft? Because
it was a great question. We actually, it was a suggestion to the patient. I just didn't listen to the slide. But I do like autograph.
Clinically, that would make
Yeah.
it would survive much longer than having it.
The patient declined. Yeah.
Next speaker, we will start from starting again, new session. So, rapid mucosal overgrowth following transmucosal Boston type 1 keratoprothesis. Pastor Asensio, please come to the podium. Be prepared also Dr. Barbieri for the next. Sorry, Surico.
Hello, good morning, everyone. I am Andrea Pastor, a resident from Branca Clinic in Barcelona, and I'm going to present a case about transmucosal Boston type 8 Pro in a patient with Stevens-Johnson syndrome that suffered a mucosal overgrowth. This is a 21-year-old female who suffered from Stevens-Johnson syndrome when she was 5 years old after exposure to ibuprofen. She had ocular severe sequelae in both eyes, especially she had underwent a lot of surgeries in the right eye with several lamellar and penetrating keratoplasties. In the left eye, she had a visual acuity of light perception. The cornea was completely conjunctivalized, and in the right eye, she had a best corrected visual acuity of 1.1 in Longmark scale after the last keratoplasty, but she also suffered candida albicans keratitis, which further worsened the prognosis. In this case, repeating a penetrating keratoplasty seemed a poor option as she had a high failure success with the keratoplasties before, so we tried to have another strategy, a better strategy, and we opted for a Boston K-Pro type 1. This was based on the adequate term film and proper eye function this patient had, even though the K-Pro alone was, we considered it was not a proper option because autoimmune patients had high risk with the Boston type 1 K-Pro. So we decided to combine it with a buccal mucosal graft, just to try to protect the K-Pro and have a better vascularization of the prosthesis. The surgery was performed in 2 stages. This is the first one, just to try to adapt the ocular graft to the ocular surface and try to get the best vascularization before, in a second surgery, have the implantation of the K-Pro. The mucosal graft was harvested from the inner lower lip of the patient, and then it was sutured to the ocular surface, very near to the recti muscles insertion. This is the appearance at the end of the first surgery, and 2 months later, the second surgery was performed. Here we can see the assembly of the keratoprosthesis. It was a pseudophakic K-Pro with a donor graft to carry the keratoprosthesis, and we can see also this mucal graft has already developed this pink color, indicating a proper vascularization. The mucosal graft was dissected and reflected about 270 degrees to completely uncover the cornea, and then the keratoprosthesis was sutured to the cornea of this patient. Once it was completely secured, the mucosal graft was placed again over the K-Pro, and it was sutured back in place. A small 3 mm trepination was performed for the optical. 2 weeks after the K-Pro implantation, we observed this overgrowth of the mucosal graft, which was also avoiding a good vision to the patient. At this point, the K-Pros, and we found these three 3 articles. In total, there were 10 cases. 7 of them were in patients with underlying pathology of Stevens-Johnson syndrome. The patients who had only resection, all of them, 3 out of 4, had a recurrence and required other surgeries. One patient was described to have a resection and diathermy, which also recurred and required retrimming and also use of mitomycin C with no further recurrence. And in last place, there was one article in which in osteodontokeratoprothesis they used resection and mitomycin C application, and those had no recurrence. Also, one of them had the longest follow-up period of 11 years. At this point, we decided to do a resection of the excess tissue and application of mitomycin C with a very low dose of mitomycin C, 0.01 for 1 minute, to try to prevent the risk of toxicity in this compromised ocular surface. 6 weeks after the cape implantation, the surgery was performed and the visual axis was completely free. Also, the visualization of the posterior pole was improved a lot, and the patient had a best corrected visual acuity of 0.22 in normal scale. Just to conclude about the mucosal overgrowth in transmucosal keratoprosthesis, a careful management is crucial to prevent postoperative complications and also ensure long-term retention of the prosthesis. This use of a very low dose of mitomycin C, we justified it by its safety profile and the need to preserve the tissue viability in particularly fragile ocular surface like Stevens-Johnson syndrome in our patient. Thank you so much.
Next speaker.
Good morning, everyone. Thank you for the opportunity to present our work that I did during my fellowship in Taiwan. And this is a study about mesenchymal stem cell therapy in some cases of acute Stevens-Johnson syndrome with severe ocular involvement. So what is Stevens-Johnson syndrome? Just to give a quick background, I know that everyone in this room knows what is Stevens-Johnson, and it is a very severe disease that can be life-threatening. It's a mucocutaneous disorder characterized by epidermal and mucosal bullous lesions, and can involve different percentage of the total surface body area. And it's a rare disease because the incidence is about 2 to 7 cases per million per year. So as I was saying, it's characterized by the involvement, the percentage of the involvement of the total body surface area. So we can have SGS, toxic epidermal necrolysis when it is more than 30%. And all variants can be life-threatening, but in the severe form, we can have a severe ocular involvement, which has also a long-term sequelae. So the ocular involvement during the acute phase is seen in more than 80% patient with chronic sequelae in up to 30% in pediatric patients and more than 60% in adult survivors. So the acute phase is inflammatory, of course, mediated. So you have like pseudomembranes, epithelial defect, and then these move through a chronic stage until you have like severe dry eye and cicatrization of the ocular surface. And of course, it's threatening for the visual acuity. We have different treatments that we can use and different therapeutic strategies that we can use during the acute phase, such as amniotic membrane dressing and systemic immunomodulation. But this is not enough to prevent the long-term sequelae such as dry eye. So what else we can do? We thought about mesenchymal stem cells, that they are available and from different tissues in our body. This is a review that we published on Survey of Ophthalmology a few years ago, and they have both an immunomodulatory effect. At the same time, they can promote regeneration of the tissues. They have been applied in different ocular surface diseases such as dry eye, corneal transplantation, and of course limbal stem cell deficiency and ocular GVHD. So our study, we use this mesenchymal stem cell derived from the umbilical cord, and we injected around 1 million cells in the lacrimal gland of the patients. The injection was performed around more than 1 month after the diagnosis, because the issue with Steven Johnson that there is a delay in diagnosis and delay in the early treatment. And what we observed that pre-injection, the Schirmer test value, so the tear production was pretty low, and the NEI, so the epitheliopathy, was high. If you look at the numbers after 1 month and also at the 1 year follow-up, we had a significant increase in terms of tear production and also improvement of the epitheliopathy. This is not usually observed because during the chronic phase, the tear production tends to go down. So probably mesenchymal stem cell injection played a role in this prevention of long-term dryness of the ocular surface. And these are the representative pictures from our paper. And you can see at 1 year, we had a pretty good ocular surface in all the 3 cases. So just to summarize, this pilot study, this case series, wants to serve as a proof that mesenchymal stem cell injection is safe and probably can be potentially significant, a good way to improve the tear production in these cases. We have a significant increase of tear production if you look at the Schirmer test, and probably targeting the regenerative and at the same time the immunomodulatory effect of this therapy, probably we can improve the long-term result in this patient. This is the first report. Probably we can think about, go into that and look at in a big trial or something like this, what are the real and statistical results of this potential therapy. Thank you very much for your attention.
The next speaker, epithelial tangle is a rare complication in intraocular lens exchange.
Yes, thank you so much for having me. So I'm presenting a case of epithelial downgrowth as a rare complication of IOL exchange. These are my disclosure. So my case is about a 72-year-old female who underwent the right eye refractive lens exchange, which was uncomplicated. However, the patient reported a poor quality of vision post-op, and the surgeon found a crack, like a scratch on the optical lens. So they decided to proceed with an IOL exchange, which was complicated by intraoperative iris prolapse. And the left eye also underwent refractive lens exchange, which was uncomplicated. So the patient was referred to the cataract service after 2 years, and with a history of a recurrent right eye iritis. At that time, the vision was 1 log bar, and the colleague detected a temporal detachment at the temporal bone with detachment folds, posterior side decay, fibrin, pupillary membrane, and a dense posterior capsule opacification. So they decided to attempt YAG anterior fibrin and posterior capsulotomy, which failed. So the membrane persists, the visual acuity didn't change. So the patient was referred to our service. So this is the clinical picture when the patient came to us. As you can see, there was a retrocorneal membrane. It was a translucent, like a sheet on the posterior cornea, but it was also on the temporal iris, and the temporal iris was bulging toward the cornea. We performed an anterior segment OCT, which showed an hyperreflective retrocorneal membrane, but also an hyperreflecting layer on the temporal cornea and on the temporal iris, and the iris was bulging toward the cornea. So we also performed an in vivo confocal microscopy, which showed a hyperreflective nuclei at the endothelium, which is typical of epithelial cells. So at that point, we highly suspected of epithelial downgrowth and listed the patient for right eye biopsy of the membrane and intracameral injection of the 5 fluorouracil. Unfortunately, the patient 2 days before the planned surgery presented to the A&E with pain, eyes, Bombay, IOP spike. The colleague attempted a laser peripheral iridotomy, which failed. So we decided to urgently take the patient to the theater. We performed a biopsy of the retrocorneal membrane. We also took a sample of the iris for the biopsy, and also a broad iridectomy, posterior synechialisis, and intracameral injection of 5-FU. The pathology report confirmed that there was a squamous epithelium into the AC, and globate cells were not identified. So it confirmed the clinical impression of epithelial downgrowth. So we carried on with the intracameral injection of 5-FU. Unfortunately, the patient developed uncontrolled IOP, so the glaucoma team took over. They performed the velvet shunt implantation, but the patient was unlucky. She developed aqueous misdirection, so she had cyclodial done and urgent pars plana vitrectomy and the repositioning of the tube into pars plana. So we carried on, once the IOP was controlled, we carried on with the injection of 5-FU with no significant clinical or confocal improvement. The patient developed bullous keratopathy with a very uncomfortable eye, and at that time she was very tired of all the journey, all the surgeries, so we decided to perform a Gaudel's and conjunctival flap. At that point the eye became comfortable, and with the unfortunately just a perception by patient. So in conclusion, epithelial downgrowth is rare, but it can be devastating. It can happen after any intraocular surgery. Since the treatment is difficult, the diagnosis can be delayed, so it's crucial to prevent, so to make sure the wounds are watertight, to avoid any prolapse of the iris through the wounds, and to document everything. We thought that in this case, the intraoperative iris prolapse could play a role. We can't be 100% sure, but it could be the entry point for the epithelial cells to the anterior chamber. Thank you so much.
Please, next speaker. Protected patch plug technique, suture therapeutic lens and corneal disc as a rescue approach for penetrating keratoplasty in complex corneal perforation.
Okay. Hello everyone. Today we present a surgical approach we call protective patch plug technique, just to face one of the most challenging situations that we can have in the operating room. Here we have a case of a 31-year-old male that suffered bilateral corneal burn, and he presents to our clinic with a complete corneal keratolysis and a 5mm central perforation that has an anterior tamponade, crystalline lens exposure. All the iris was syndicated anteriorly. We went into the operating room. Here we can see as near as is the crystalline lens exposed also. Everything is closed, there is no space. So here is clear, if we perform the standard penetrating keratoplasty, we have high risk of supracortical hemorrhage to damage the lens, the iris, and is the only functional eye of the patient. So in this case, we think that two stages strategy was a better option to solve this problem. So we've checked that the patient has already a bandage contact lens, so we decide to suture this contact lens into the cornea with a 10-on nylon in a running suture in order to create a pseudo chamber before going to dissect all the anterior synechiae. Obviously, it's not enough stability, so then we proceed to the second stage of our plan, that was to introduce a plaque of cryopreserved cornea in order to stabilize this perforation. As we can see here, beneath the contact lens, we introduce a 6 mm disc of cryopreserved cornea, which is not optically functional, and we stabilize the chamber, and then we can retire the bandage contact lens. Particularly in this case, even with this approach, there was too much pressure. We decided to suture the patch and the plaque, and then to proceed with a standard penetrating arthroplasty, as we can see here. And now I can show you a small video of all the key steps of this surgical. So we can see here there is no any space. Everything is synechiae. So we perform the running suture. Here it's technically demanding because it's a high potency flow, but it's not impossible. The sharp point is very helpful, and peripherally is where we have more integrity of the cornea. We make an hexagon in order to create some breaches where under this we can access into the anterior chamber, as we can observe in the following step. Here we are introducing the cannula beneath the contact lens just to start creating the space. And it's very easy to dissect all the iris, which is into the posterior stroma. Here with the interconverted osity, we can check that we also have some space, and it's very easy to introduce the plaque. And then when it's stabilized, we can retire the bandage contact lens. And in here, as I told you before, we decided to suture the plaque because there was too much pressure. And also, as you can observe, there are some points of chirurgical even with the stitches that we put. If we make a comparative analysis of the different options to solve these kind of perforations, obviously tissue adhesives in this case is contraindicated. Tectonic mini dissect, it was not a good option because in this case we have a large perforation that was not too much stromal support, and there are some perforation that can make that the gas or air escape very fast and make it correctly heal. And obviously we have a high risk of unjustifiable risk of catastrophic intraocular content expulsion if we perform a standard keratoplasty. We think that this approach avoids open sky complications. We have accessible materials. Obviously, there are some devices as head-card keratoprosthesis or so that are specifically for that, but everyone has a bandage contact lens in your clinic. Obviously, it's technically demanding, but we haven't used the Feringa ring here. It's not impossible, and it's a safe and highly effective bridging strategy to secure the globe prior to the definitive keratoplasty. And here we have the final result of the patients. We have combined a little bit more surgeries, but it's a pretty good result.
Now Pasquale, atypical Brown-McLean syndrome.
Good morning, everybody. I'm Dr. Pasquale Andrea, and today I will tell you about an atypical Brown-McLean syndrome. Okay, I think it was a Saturday morning, and I was in the accident at emergency ophthalmology clinic in Parma, and a 54 years old woman complained about vision loss and foreign body sensation. A little bit of anamnesis. Her left eye is amblyopic. She had no history of prior surgery in that eye. Okay. Her best corrected visual acuity that day was counting fingers and was not improving with pinhole. She was a very precise woman, and she brought with herself the last visit when her left eye best corrected visual acuity was 20 out of 50. Okay, at the slit lamp examination, as you can see, there's a left eye annular corneal edema and opacity, sparing the 5 mm centrally, a mild putata, and the paracentral superior subepithelial bulla. The right eye is completely normal, so I started hyperosmotic artificial tears 5 times a day and botoprednolol 3 times a day. Okay, these are the tomographies, of that day. As you can see, the right eye is completely normal. This is the OCT that shows the epithelial edema. so the bulle, and this is the endothelial count. Okay, a little digression. This is how my girlfriend thought was my Instagram at that time. Nothing more far from reality. It was more like that. Okay, why I'm telling you this? Because the diagnosis of Brown-McLean syndrome I made, it came from an Instagram post that I had seen months prior, and when one evening, going back from work, I kind of flash of inspiration, and I said, oh, I've already seen that eye somewhere. I retrieved the post and made the diagnosis. Okay, let's go back to the cornea service. 2 weeks later, okay, the visual acuity improved to 20 out of 200. The macrobulla was persisting, but the pachymetry was improving, and this is stonks. The right eye tonometry is good, the left eye tonometry is not good, this is not stonks. Okay, the gonioscopy was normal, there was no orange pigment at the shoulder line or on the endothelial surface. The fundus oculi showed us a tilted disc and a staphyloma, so we decided to de-escalate loteprednolol to 2 times a day and start a fixed combination of dorsifamide and timolol. We programmed visual field testing and an optic nerve and ganglion cell OCT. Okay, as you can see, the left eye visual field has a resemblance that is uncanny with the slit lamp exam. But for those of you more into perimetry, there is a nasal step up there. Okay, going back to cornea service. Okay, visual acuity improved again, 20 out of 63, macrobulla resolved, tonometry still high, 29 millimeters of mercury, so we stopped loteprednolol and started latanoprost. A visit in a week later, cornea service, back to normal, 20 out of 50, persisting edema, but no bulla anymore, tonometry is good, we continued the therapy as it was, programmed a visit in 4 months, and I was like that. As of now, I do not work in the Parma University Hospital anymore, so I asked my colleagues to send me the result of the last visit, that was about 10 days ago. Unfortunately, visual acuity drops back to 20 out of 200, the macrobulla reappear, the tonometry was 25 again, so they added brimonidine and restarted loteprednolol, programmed a visit in a month with visual field and OCT, and I was, oh shit, here we go again. Okay, I know I'm late, but these are take-home messages. Okay, classical Brown-McLean is usually post-surgical. In the past, after itch and etch, peripheral, slowly progressive, but centrally sparing. Why this case is atypical is an amblyopic eye. She had no history of prior surgery and had a significant IOP elevation. I don't think it's entirely steroid related. The orange pigmentation is a hallmark feature, but it's not always necessarily present. Conservative treatment is appropriate, but recurrent bulle require close monitoring to avoid infections. And the question is, could we suggest an endothelial keratoplasty? Thank you for your attention.
I have one question for the first one, the rapid mucosal overgrowth following transmucosal. No, sorry. Not for the first one, for the second, to the umbilical cord derived mesenchymal. Are you thinking to also, with this good outcome, to start to inject also the conjunctiva where you have mucipar production, because you are almost stimulating one part of the...
Yeah, thank you for the question. There are multiple, they've studied different routes of administration. There are some trials in the US where we were doing subconjunctival injection in PED, persistent epithelial defect, or even eye drops with exosomes. So there are multiple routes of injection. We decided to target the lacrimal injection because you have a scarring and inflammation happening in the lacrimal gland in this disease. So this is a strategy, but of course needs some validation. And probably subconjunctival or even eye drops could be even more feasible to. But yeah, of course, yes. Thank you very much.
Well, can I ask you a follow-up question?
Yeah.
We find often even if the lacrimal gland function returns, but if the lacrimal gland and the axillary lacrimal gland orifices are blocked, and if they are occluded, then you don't get the tears coming down. So how do you overcome that with the injection? And was that only one injection always okay, or you have to be multiple?
So thank you for the question. I think that this is a combined, a supplementary therapy, because, for example, amniotic membrane transplantation and dressing, these can address the scarring consequence at the, and the fornix and at the other lacrimal accessory glands. So I think this is a combination of the treatment, and mesenchymal stem cell can support the anti-inflammatory and immunomodulatory and both regenerative, issue. And about the, sorry, what was the number of cells? Yeah, just one shot. We just wanted to show, this is a compassionate, what they come from a Taiwanese company, so pre-made with good manufacturing practice and everything, so it's not easy to have these cells, so we tried it and they are safe, at least. Thank you.
Thank you. Sorry. I have one question for this, the paper on Stevens-Johnson syndrome with buccal mucosal overgrowth. Stevens-Johnson syndrome doesn't affect only the eyes, it also affects the oral mucosa, other mucosal surfaces of the body, so you're taking diseased mucosa from the mucous membrane of the mouth and transplanting it to the eyes. So maybe there is something to do with the mucosa that and the quality of that you're transplanting, rather than just the actual overgrowth, which is coincidental. And what I've also seen in my experience is that the thicker the mucosa you have when you harvest it, and the more the submucosal tissue, then the more because the proliferation is not of the epithelial cells, it's of the fibrous tissue. And perhaps you need to have a thinner mucosa than the one you had used, and then perhaps also the question that it's a diseased mucosa you're transplanting.
Well, our patient, she did have a good mucosa quality. She also had some sequelae in the respiratory system and so, but prior we thought the mucosa was good quality. We also saved the mucosa for the inner lip instead of the inner cheeks, just to try a thinner graft. This is the adaptation we made, but it's really interesting your point about it's also Stevens-Johnson and it's not only an ocular involvement.
Do you think that the choice of keratoprosthesis, if you had chosen a type 2 Boston keratoprosthesis, you would not have this problem of mucosal overgrowth, because a type 1 is typically not designed to be placed under a mucosal graft. And in your comparative, when you quoted the other studies, when you compare with OKB, there also you had the optical cylinder protruding beyond the mucosa. Despite that, you can get mucosal overgrowth if the mucosa is too thick. And your follow-up is only 6 weeks after you have done with the mitomycin. So I would be worried whether that's going to expand in the long run, because Stevens-Johnson's syndrome is not a great indication for a type 1 K-pro, so we always try to do it.
Maybe it has misunderstood as the surgery of the trimming and the mitomycin C was 6 weeks after the implantation, but the follow-up is up to 18 months.
Okay.
Yeah, and there have been no recurrence. We thought about also the K-pro 2 option, because it's more suitable with the mucosal approach. But in Spain we have some regulatory limits about the access to the K-pro type 2. So it's much more easier access to the Boston type 1 keratoprosthesis.
I have a question for Dr. Palmieri. That's could you tell us the technique you used for your 5FU concentrations? Was it mixed with a OVD, or was it just injected?
Yes.
Is a
So it was 0.5 in 0.1. We didn't mix with OVD yet, so probably we should have done a coat with a dispersive OVD before injection of the.
So you diluted, you mixed it into the OVD and injected the OVD?
No, I mean, we didn't do a coat of the endothelium with the dispersive OVD, so probably that contributes to the bullous keratopathy following the injection.
Okay, I mean, I'm asking because it's you want to keep it there. When you just inject it, it's a very viscous. It's along with just dissolved in BSS, it's going to wash out almost immediately. And I found when you do put it, inject it, and actually mix it up in a dispersive OVD, it will stick around longer. It will actually stick into the areas that you need it to hopefully affect and kill the epithelium.
I have a follow-up question on this. Almost all epithelial ingrowths are due to a leaking wound. It is through that wound, which is limbally located from where the stem cells are going to grow in. It's very rarely due to implantation of cells directly in the eye, because if they are in motion, they don't really stick and expand. And the fact that there was iris prolapse during surgery suggests that the wound was poorly constructed. But normally a proper wound is such that you don't get intraoperative iris prolapse.
Sure.
So you would probably have had a leaking wound as a cause of your, because just one episode of iris prolapse on its own will not give you epithelial ingrowth.
Sure.
And that was missed, and in many cases I found either it's noted and not treated, and they put a bandage lens and go away, and put a bandage lens and go away. And for the life of me, I've never understood how a bandage lens will stop a leak, but that's what people do. And the persistent leak creates a fistula, and then you get the problem.
We didn't have a video from the original surgery because the patient underwent surgery privately, so we only got the photo that surgeon sent to us, and we only got the note of intraoperative iris prolapse. So yeah, but I agree, probably it was the leaking wound rather than. Thank you.
I think the case clearly highlights that your initial approach should be much more aggressive. Otherwise, long-term outcome of epithelial growth usually is not great.
Aggressive earlier. Yes, as an earlier intervention.
Sure. Thank you so much.
A question for Dr. Vila. With a patch bug picking. Unless I missed it, how long did you wait before you ended up with your full therapeutic keratoplasty after the plug technique?
It was simultaneously. So, but here the focus was on the patch plug. Okay, but in this case, the patient suffered a bilateral corneal burn. He has a stem cell deficiency. He has suffered several amniotic membrane transplants, a SLED. And here, after we perform, we know that there is a high risk of rejection in this eye, okay? But simultaneously, we combine with a SLED transplant and an amniotic membrane overlay.
So you did this just to do anterior segment reconstruction under the plug, and then still do the therapeutic. Did you consider waiting after you did that reconstruction with the plug on to let things stabilize and quiet?
It was not enough stable because, as you can observe in the OCT, the keratolysis is very expensive. So every stitch we make there generates a perforation and corneal melting. So we needed to do it in that moment. So we combine after, that was not the objective of the presentation, but after the high diameter penetrating keratoplasty, where it was 9.5, we performed the SLED transplant and membrane overlay.
One option I've done in these large perforations is if you take viscoelastic, if you take viscoelastic and try and inject that very cohesive, even here on GV, between the iris and the cornea, where it is touching, right? So you can create a space, and that gives you enough space to then close the gap, because you were right, you rightly mentioned you couldn't use glue because it was too large, but you could then create a space and put your patch without having to do the contact lens first.
Very interesting approach. In this case, what was quite difficult to access into the anterior chamber, and also, as you can observe, the perforation was central, and it was a clear lens of the patient. It was risky to go inside with cannula to damage the crystalline lens. So, normally we try to think simple in these cases. Okay, patient already have a bandage contact lens. Let's try to suture and make a watertight shadow chamber with the bandage contact lens, and it worked.
Well, so it won't be watertight because you said every time you suture the cornea it was a leak. But you still have to go in the space with your cannula after you put the contact lens. So that space doesn't deepen just by putting the contact lens. You have to create and you're risking the lens as much as if you went with your cannula through the large opening. You go through the wound, you don't have to create a paracentesis, you go through the lip of the wound with heel. I'm just taking an alternative approach. You can then put the heel on, create the peripheral space, and then put your patch and then consult and then do your graft. Just an alternative approach.
One other approach that can be done is a graft over host technique. So you can take a donor tissue, split it, take the endothelium, keep it aside, and then do your partial trephination, make peripheral entry, and then suture the donor button on the cornea. Then do all your manipulations that you want and cut out the posterior disc. Place your sutures, and at the end, you can take the endothelial tissue, like a DSEC graft, put it inside the eye, put an air bubble, so you have good control and you don't kill your cells in the graft. So that's what we do for pediatric eyes. So even in this scenario, that could be a great option and much more control, easier for somebody else to replicate. So trying to suture a contact lens where you say the peripheral cornea already has blood vessels, it's thin, you may cheese wire and you may end up making it more complicated. I do it with a microkeratome myself, but just like you asked for a DSEC tissue, if you had that, you can use the anterior cap first, suture it in place, do all your manipulations, then slip in the DSEC graft from 2 sutures just to a pull through, and that would work the same.
Thank you.
Next speaker will be clinical evolution of multicontact imaging of late onset post-trauma degeneration after corneal cross linking for keratoconus. Dr. Avoldo.
Good morning again. My presentation is about the severe focal stromal degeneration. We had 2 cases in our department in San Marino Hospital. The first one is a 46 years old female who had cross-linking performed 14 years before in both eyes, but underwent DALC in the right eye because the keratoconus was already advanced. At time of presentation, she had a 0.5 logMAR best corrected visual acuity, and 11 months prior the last visit, she didn't have this roundish lesion that pulled with fluorescein but doesn't stain. This lesion is particular because as some clinical feature, it's inside an ACE area. It's well defined and has this roundish epithelial ingrowth post-LASIK-like remnants, and these iron lines all over the lesion. This is the tomography of the eye. The Kmax was 56 and the minimum thickness was 256, and before the cross-linking 14 years before it was 454 microns thick. Also, the anterior segmentosity has some clinical signs like the disruption of bone layers membrane, and it's filled with epithelium-like material and has these undermined borders. It doesn't go straight to the posterior stroma, and there's these hyperreflective contours and oval, roundish spots noted inside the lesion. Also, we performed a confocal microscopy and a scraping to assess an infection, but it was negative. We found out these polygonal polymorphic epithelioid cells a reduction of the subbasal nerves, and fibrosis of the remaining stromal bed. That's important because we don't know the origin of this degeneration, but it's supposed that it's caused by either the effect of UVs on the keratocytes that cannot regenerate, or the fibrosis that creates a barrier that cannot feed the anterior stroma. Then, 5 months later, we had a progression to 1.0 best corrected visual acuity and an enlargement of the vision that now is 1,904 microns, and the residual stromal bed decreased from 71 to 56 microns. Also, the tomography, we can find 3 diopters increase in Kmax and a reduction of the thickness. So, this is the difference, and we decided to underwent to go for a surgery. And whilst the other case is a 39 years old male who had bilateral cross-linking 9 years earlier, and has 0.2 and 0.1 logmark best corrected acuity. The pattern of the lesion is very, very similar, either to the slit lamp, to the confocal microscopy, the tomography, the anterior segment OCT. It resembles a lot the first case, but the difference now is that this is a little bit mild, and it doesn't go, isn't as fast in both eyes, the progression. Because we can see here the anterior segment OCT, the right eye is worse than the other one, than the fellow one. But also, we found out that 5 months later, the best corrected visual acuity was the same. We had a slight enlargement of the lesion and a slight reduction of the residual stromal bed, but we decided to wait. So we counseled the patient. We told him that the left eye was stable and the right eye had a little bit of progression, but we suggested him to have a contact lens, a scleral contact lens, and now he's in follow-up. We're following him. There's no worsening of the condition. There are some cases described in literature by Trabacher and others. The difference, the lesion is very similar to what's shown here, but they had an earlier follow-up time after 6 years and 3 years from cross-linking, but we can see that either slit lamp examination and anterior segment OCTs are kind of the same. We don't know why this happens. The two main hypotheses were the keratocytes depletion and the fibrosis of the stroma. These are the cases of Trabacher in his team. He called them severe focal stromal degeneration, and all of his patients underwent about. He had this therapy. We have to assess this condition every time we have a keratoconus and a cross-linking, and even after years, this condition can occur. So we should be pay attention. This is the paper will be on cornea this week. Thank you very much.
Next speaker, Burza-Maria syndrome after deep anterior lamellar keratoplasty. Please.
Yes, it's a very difficult name. Pomarbeolo. I'm Zaina Pomarbeolo, and I'm going to be presenting one of our cases which developed Urex-Zavallia syndrome after deep anterior lamellar keratoplasty. Urex-Zavallia syndrome is characterized by a fixed dilated pupil, iris atrophy, and posterior synesthesia. It is reported after various ophthalmic procedures, but it is mostly seen after keratoplasties, especially penetrating keratoplasty. Our patient was a 26-year-old male. He had a visual acuity of counting fingers from 2 meters on the right eye and 0.3 on the Snellen chart on the right eye. On the microscopic evaluation, bilateral walk T3s were seen. The fundoscopic examination was unremarkable. Here we can see the corneal tomography of the patient, which demonstrates advanced keratoconus features. He has a very steep inferior cornea and high levels of back elevation is seen. So we performed DOLC under general anesthesia on the right eye. There was no major intraoperative complications, but there was a small microperforation of the desmoid membrane intraoperatively, so we performed an anterior chamber air injection. On the postoperative day 1, the patient's intraocular pressure was 50 millimeters mercury, so we treated him with intravenous mannitol and topical antilocomotive therapy. Then his IOP was normalized. On the postoperative day 2, the patient's intraocular pressure was normal within the normal range under birmonidine and timolol eye drops twice daily. But after discharge, patient did not attend his follow-up examinations. On the postoperative month 2, the patient showed up with ocular pain. He was non-compliant with his treatment. He stopped using all his medications, and his intraocular pressure was at 47 millimeters mercury. Then we treated him again with intravenous mannitol and topical therapies. His IOP was normalized. After 15 days later, when he showed up to his follow-up exam, his IOP was in normal range, but he had a fixed dilated pupil and there was dense iris pigment deposition on the lens. Here we can see the photo of the patient. The cornea is clear, our sutures are intact, but the patient has a fixed dilated pupil and there is a dense iris pigment deposition on the anterior capsule surface of the lens. On the second postoperative year, despite the patient had an irreversible pupillar dysfunction, his visual acuity was improved and he had no complaints of photophobia or glares, and there was a significant decrease in iris pigment deposition on the lens surface. Urate-Savellia syndrome was first described in 1963 in a series of patients undergoing penetrating keratoplasty, most of which patients was keratoconus patients. The author described the initiating factor as the usage of mydriatic drops postoperatively. Urate-Savellia syndrome is mostly reported after keratoplasty procedures, but it can be seen after various ophthalmic surgeries such as trabeculectomy or cataract surgery. It usually occurs within the first 2 weeks after the surgery, but late onset cases such as our case have also been reported. There are some identified risk factors, which includes increased IOP either intraoperatively or postoperatively, the usage of mydriatic agents postoperatively. Keratoconus patients are especially at high risk group, and air or gas injection in the anterior chamber. Proposed mechanism in Urate-Savellia syndrome's pathogenesis include iris ischemia due to increased intraocular pressure or iatrogenic iris trauma. Keratoconic eyes are more susceptible for this kind of ischemia. Possible mechanisms for this include low ocular rigidity of keratoconic patients, leading to obstruction of peripheral iris vessels at the point where they enter the sclera, or structural differences in the iris and the pupillary sphincter muscles may be present in this kind of patients. So in conclusion, although rare, Urate-Savellia syndrome should be kept in mind after DOLC, especially in keratoconic eyes with postoperative intraocular pressure elevations. Early recognition and management may limit long-term complications. Thank you for your attention.
Concurrent persisting marginal degeneration confused endothelial corneal dystrophy, diagnostic challenges, and surgical complications. Please.
Hi everyone, I'm going to present a case of concurrent pellucid marginal degeneration and Fuchs endothelial dystrophy.
These two pathologies have two different mechanisms. Pellucid marginal degeneration is in inferior ectasia and it causes high irregular astigmatism, while Fuchs is endothelial dystrophy and it causes stromal edema. Our patient was a 67-year-old man with progressive bilateral visual decline with no history of astigmatism before the age of 50, with a vision of 20/40 in the right eye and a vision of 20/80 in the left eye. We did the slit lamp exam. We saw that there was inferior ectasia and goutte in both eyes, and the left eye also showed stromal edema and stromal fluid cleft at the area of minimal thickness that is visible on the OCT and also the slit lamp. So we did a tomography. We saw the classic crab claw pattern with a Kmax of 77.7 diopters, minimal thickness of 505 microns, and the inferior displacement of the minimal thickness point related to the Kmax point. The tomography and specular microscopy on the right eye confirmed that this is a bilateral disease but asymmetric. So we faced an important question: which one of these is the main reason for visual loss? So we thought that we could try to do an RGP lens trial in order to see if the anterior surface is the main reason. We did that and we obtained only 20/40 vision. So we decided that the stromal edema was the main cause of visual loss. Next, we had to decide what kind of surgery we had to do. The first one to exclude was bulk because it did not address the endothelial dysfunction. The graft itself would become edematous and there would be a high risk of double AC formation. So mainly we had to decide between PK and DMEC. We thought that PK would be a risky procedure, would be an opal sky surgery. It would need a large and decentered graft that would cause high astigmatism, high rejection rates, and also the risk of post-PK ectasia. So we thought that DMEC is a reasonable option. It would address the endothelial dysfunction. It would preserve the ectasia, but we think that this is manageable post-operatively with correction. There is also literature that supports this idea, stellare, that most of the patients with pellucid marginal degeneration can acquire satisfactory vision only by spectacle correction despite having high astigmatism. So we decided to do the DMEC triple procedure using the 9mm graft and the monofocal plus IOL. We had a bit of a challenge in the IOL selection problem because the steep CK was 62 diopters, so it was unreliable. So we thought that we could use the K average for both meridians and use the K keratoconus formula while using a myopic refractive target. There's a meta-analysis wrote by Wright-Blatt that says that K keratoconus is the best performing formula in severe keratoconus. 3 months later, we did the tomography again. We can see that the ectasia is preserved as we expected. We can see that the edema is gone as we expected, and we have a rather very thin cornea. And something we did not expect was the stromal fibrosis on the OCT. We can see on the difference maps that, as we expected, there's a large area of thinning. But interestingly enough, we have on the anterior curvature map, we have superior steepening and inferior flattening, which may mimic regression of the ectasia, but instead we have an increased Kmax of 79.45. Also, we had a hyperopic biometry surprise, which left us at the best spectacle correct visual acuity of 2033. We did a literature review on this subject. We searched for cases with stromal ectasia and endothelial dystrophy. We found 36 reports, out of which most of them are keratoconus and Fuchs dystrophy. We found only one more pellucid marginal degeneration and Fuchs endothelial dystrophy, which was treated with wedge resection. So our case would be the second ever reported one, and the first one treated with DMEC. Out of all reports, only 16 of them needed surgical intervention, and out of which 9 of them required endothelial keratoplasty. So my take-home message is to plan the surgery by the dominant mechanism and not only by the tomography and topography. We did the RGP trial, which told us which is the dominant cause of visual loss. The DMEC resolved the corneal edema and preserved the ectatic cornea, which we will manage later with correction. I'd like to thank my mentor and also my team for making this work possible, and also thank you for the attention.
Thank you. Next speaker, when all else fall. 125 black to the rescue in refractory ocular surface.
Good afternoon, everyone. My name is Noah Karp-Cohen. I'm an undergraduate senior at Brown University and a research associate at the Bascom-Palmer Eye Institute in Miami, Florida. I'm very excited to be here with you all. Thank you so much to SICSSO for this opportunity, and I have no financial disclosures. So without further ado, when all else fails, I-125 plaque to the rescue in refractory ocular surface squamous neoplasia. So our case begins with a 36-year-old male who walked in and was referred to the Bascom-Palmer Eye Institute for a second opinion on a suspicious conjunctival and corneal lesion on his left eye. 6 months prior, he had seen the incredible Dr. Enrica in Mexico City, but had a negative biopsy from malignancy. However, due to the highly suspicious nature of the tumor, the patient was still put onto interferon 4 times a day for 6 weeks prior, empirically based off the suspicious nature. So what could be hiding in here? Well, a look on the OCT would reveal a diffusely thickened and hyperreflective epithelium with an abrupt transition noted at the yellow box. So again, what could this be? Well, if you saw the title of the presentation, you're also likely thinking ocular surface squamous neoplasia. And as a quick review of how to diagnose OSSN via OCT, there's a couple important steps to note. The first is to find the normal epithelium, which is around 50 to 60 microns and darker in appearance. Next is to trace the basal layer of the epithelium. And then you can assess the main lesion, looking to see whether the tumor is epithelial or subepithelial. And then you ask yourself, does it have a thickened, hyperreflective epithelium, typically greater than 120 microns? And then you finally look for an abrupt transition between the normal and abnormal epithelium, which can be noted by the purple arrow. So this would be a textbook case of ocular surface squamous neoplasia. So based on the clinical results that we found, we decided to pursue a biopsy, and the corneal biopsy revealed cornea intraepithelial neoplasia on the left eye. However, limbal biopsies taken at 12, 3, 6, and 9 o'clock were negative alongside ulnar conjunctival biopsies, which were also negative. So when reviewing our treatment options for ocular surface squamous neoplasia, we have a lot of different options. First was surgical excision with cryotherapy. However, this was unfavorable given how extensive the procedure would have to be, likely leading to limbal stem cell deficiency. And without a precise location of the limbal origin of the tumor, this could positively lead to positive margins. Next, we have topical chemotherapies. Examples include mitomycin C, 5-fluorouracil, and the interferon alpha-2 beta, which was attempted before. So what did we do with this patient? We decided to throw the kitchen sink. So as I mentioned before, there were the 6 weeks of topical interferon for four times a day. And then when that didn't show much promise, we moved to 4 cycles of topical 5-FU 1% for 1 week on, 3 weeks off. Although it showed marginal improvement, it wasn't necessarily what the physicians were looking for, so they then pursued 2 cycles, 1 week on, 3 weeks off, of 0.04% mitomycin C 4 times a day. And finally, the physicians also pursued a subconjunctival injection of 25 milligrams of 5-FU. But again, there was not much resolution, unfortunately. And as you can see here on the slit lamps, you can still see the residual tumor around the limbus, and outlined by the white arrows and the white asterisk being the thickest portions of the tumor. And the OCT confirmed our suspicions that the tumor still persisted. So what should we do now? We're running out of options. Well, to quickly review them, surgery was unfavorable. Topical drops had yet to show promising success. So what could we do? Well, just by coincidence, the patient happened to be moving to Cincinnati, which is where Dr. Basil Williams and Dr. Mauro Di Niccolo were located, and they had the novel idea to attempt a plaque radiotherapy for this intraepithelial neoplasia. So they placed an 18mm I-125 plaque of 50 grays over the span of 97 hours, and this larger diameter allowed them to cover the entire cornea, the limbus, and 3 additional millimeters of the surrounding conjunctiva around the affected area. And the results speak for themselves, seeing the slit lamp on the left and the cornea and the OCT on the right, with the patient being cancer-free for 65 months. The patient did, however, develop a posterior subcapsular cataract at 32 months, but after cataract surgery by Dr. Caterina, the patient is now 2020. So as a few final take-home points, this was the first reported case of plaque radiotherapy successfully being used for both chemotherapy and immunotherapy-resistant invasive neoplasia, intraepithelial neoplasia. And therefore, this should be considered an option in your toolbox when combating particularly unresponsive ocular surface squamous neoplasias that were not effective with topical therapies and were poor surgical candidates. Thank you again, SICSSO, for this opportunity and for your attention.
Thank you so much. Multidisciplinary surgical management of refractory glaucoma and corneal decompensation in affecting monocular patients. Policy, please. Is not here.
Hello, my name is Clara Bons. I'm a resident at Branca Ophthalmology Center in Barcelona. So, when we have a patient with only one functioning eye, every surgical decision carries a different weight. Today I want to present a case that puts that reality front and center. Our patient is a 63-year-old male with a long-standing progressive vision loss in his right eye. He had undergone congenital cataract surgery at 2 years old in his right eye, which left him aphakic, and his left eye had been in disease bulby for a long time. Currently, he's on hypotensive medication with latanoprost and etorsodil once daily in his right eye, and timolol and brimonidine twice daily, also in his right eye, and prednisone drops 3 times every day. Vision, best corrected visual acuity in the Logmore scale was 1.6, essentially hand motion, with hyperopic refraction. So at presentation, we see that this patient has a hyperemic conjunctiva with diffuse stromal edema and epithelial bullae, grade 2-3 bullous keratopathy. Endothelial cell count was not measurable, and the optic nerve was not visible due to medial opacity. Central corneal thickness was 769 microns, and IOP corrected by central corneal thickness was 35.2. So we decided to stop latanoprost etorsodil drops and leave him only with timolol brimonidine drops twice daily, taper down prednisone drops to once daily, and add oral acetazolamide twice daily. After 1 month, there was no improvement. Low vision and corneal decompensation persisted. Central corneal thickness rose to 789 microns, and IOP oscillated between 32 and 37. So at this point, it was not a question of whether this patient needed glaucoma surgery, but of how to perform it. We had a joint revision with our glaucoma team, and posterior segment evaluation was performed, which indicated that in this patient vitrectomy was feasible and indicated. And we decided to perform a triple procedure of penetrative keratoplasty, parascolanoid vitrectomy, and pole device implantation. So surgery was performed with general anesthesia. First, the drainage device was fixated on the supratemporal quadrant. Then parascolanoid vitrectomy was performed with a temporary keratoprosthesis. Then penetrating keratoplasty was performed, and finally the drainage tube was inserted into the vitreous cavity. So after 1 month, we saw that in the early postoperative period, IOP control was was good, it was regulated. And after 1 month, the IOP was maintaining it between 16 and 18, so we decided to remove the intraluminal stent of the pole device. And after 1 year, IOP is stable at 17 with premoniting timol drops twice daily. We have a well-posed transparent corneal graft, and visual acuity has improved to 1.05 in the Logmar scale, which is more than threefold improvement from the baseline. So when we have a patient with a penetrating keratoplasty and a glaucoma implant, the main challenge is not the IOP, which tends to maintain, but the corneal graft survival, which is in the literature of 17.5 in 5 years. Combined versus sequential surgery has shown no difference, which supports our single-stage approach in this patient for whom we wanted to avoid 2 anesthesia and double the surgical risk. When a glaucoma drainage device is present, we have seen that in the literature there is a high graft dislocation rate in endothelial keratoplasty, which shows us that glaucoma drainage devices and corneal grafts coexist uneasily. And when the tube is in the vitreous chamber rather than the anterior chamber, there is a superior graft survival rate. Regarding the pole glaucoma implant, IOP reduction is sustained at 3 years with an IOP of 14.9 in the literature at 3 years. The intraluminal stent, as used in this case, allows us for good early hypotony control, but there is no published series on simultaneous PK and pole glaucoma implants, so this case is an early contribution to an emerging evidence base. And as take-home messages, the tube position, not the surgery timing, is a decisive variable. We have to prioritize the cornea long-term, as the EOP tends to hold well, and this case opens a chapter that does not yet exist in the literature. Thank you.
Here. So on that patient which is the case with the multimodal imaging in the cross-linking, I did not see in your presentation a mention of corneal sensations. When we do cross-linking, we are damaging not just the keratocytes, we are also damaging the nerves. And particularly when you take off the epithelium, you're taking out the entire subbasal plexus with it. In some patients, nerve regeneration is poor, and they will undergo neurotrophic changes and melt more quickly. And that's why when you see these things happening which you don't understand, it's very important to check sensations in different parts of the cornea. Did you do that, and were you able to comment whether there was neurotrophic element to it?
We usually assess with the aesthesiometry the sensation, but this time we didn't because the patient was an old one, yeah. So she never had problems with neurotrophic or aesthesia, so we just go ahead.
I just want to mention that if you look at the papers published, both by whole mount staining and by confocal microscopy, there are huge amounts of nerve abnormalities in keratoconus corneas. And on top of that, when we intervene, we upset that balance they have. And it's likely that, I'm just suggesting that this might be a reason for the melting you've seen and the changes you've seen in this patient. And I think the same was for the Uritz-Zavallo syndrome. Why it occurs, ischemia is the explanation, but you get a lot of pigment release, and pigment release is a feature of ischemia. We know that, but sometimes we get Uritz-Zavallo without pigment release, and that again may be that the nerve abnormalities seen in the cornea may be also reflected in the iris, particularly the autonomic nervous system being affected, causing more susceptibility to permanent dilation. That's a point here.
We're asking that paper, what was the intraocular pressure the first post-op measurement after that procedure?
After the procedure, the first IOP measurement was 50 millimeters mercury. We treated him with intravenous mannitol and topical drops, and he responded well, so we didn't surgically intervene.
What was the history of the patient? Did the patient complain of intense pain that evening? Did you?
Yes, he had a severe headache and he was nauseous, so we did an IOP check.
Right. So his pressure may have been higher than 50.
Yes, it may be.
Okay, because that is, in my experience, that's the inciting factor. Is this very high spike of intraocular pressure and the iris ischemia.
And not to forget that when you measured it, it was a while after the operation.
Yeah.
And some of them may not have a high pressure when you measure it, but may have had a spike in that intervening period, and it might have even been higher than 50. So a question for you don't have to answer. What is the highest the eye pressure can ever get to? Something you can think of and let me know later, and why.
Thank you.
I think one point is that when performing a dull surgery and you encounter a perforation, and to prevent a post-operative double anterior chamber, you introduce air or a non-expansile 20% SF6. It's important to think that patient can develop a pupillary block. So either you do an intraoperative inferior surgical PI or dilate the pupil and see the patient 2 hours post-surgery to ensure that your inferior edge of the bubble is clearing the pupil. If not, you have to burp out some air. So don't send the patient home. So that's very important. So if you follow these steps, I don't think you will encounter a Urey-Zervelius syndrome.
And that's particularly true for phakic eyes, where you're putting more air in a very small space.
Yeah.
But not to forget that even after penetrating, so it's first reported after penetrating keratoplasty, where the pressure spikes occur because of the nature of the operation and not for any other reason.
I have a question for near Dr. Cohn on his I-125 therapy. I just wanted to make you walk, take your steps.
Thank you.
Yeah, welcome. The question is, so you showed that wonderful picture over 5 years post-op. What's been the assessment of the stem cells at that point in time? The patient's gone through multiple therapies with potential toxicity, including plaque. And what is the status of the stem cells right now? And you showed a picture without any fluorescein staining, so it's hard to assess them. And what's your plan to follow that?
That's a great question. So the plaque was primarily considered for protection or maintaining of the stem cells, because we know that surgery would have been incredibly expensive. And I don't, off the top of my head, have the current status of the stem cells, but I can try to find that for you afterwards or look back into the patient review. My assumption would be that they're doing a lot better just based off how the slit lamp was looking even without fluorescein, but the specific health of the stem cells, I would have to check back with you, if that's all right.
What about other collateral effects? And you did calculation with radiotherapist?
Yes, so regarding the calculations, I guess for the, so we use 50 grays, and grays are, like, the way that it's calculated is in collaboration with the amazing biophysicists that we work with. So it's specifically based on the care team will provide a certain area that they want to cover and a depth specifically. So for example, with the cornea, you would say maybe about 500 microns plus a little extra to make sure. And then for the sclera, you could say 1 millimeter plus a little more. And then they do the calculations based off the size of your CMS plaque, and then how much, like, that gives you the resulting grades that they do for us.
Yes, please. I have one question for Dr. Spons.
Can I ask one question to him? Just to finish. I've had a similar case, and I've got a much simpler approach. Is you do alcohol delamination of a large area of the corneal epithelium. If you see even the gray stone extending to the limbus, you presume that is the limbus that's affected, because usually there is a limbal involvement, although your multiple biopsies showed it was negative, but it comes from the limbus, we know that. And rather than irradiating the whole limbus, what we've done is you do put a well large enough to cover the entire area, and instead of 30 seconds of alcohol, you need to keep it longer because the epithelium is thicker, and it goes, and then you take it all off, and you virtually affect a cure. But you affect the limbus, you involve the limbus of the site where you see the zone extending into the limbus. So that worked for me as well, exactly same outcome, and we've got now 10 or 12 year follow-up for that patient. But we had used the other chemicals as well in addition in the post-op period. Like we used mitomycin C and interferon for this patient in addition to this procedure.
Thank you so much.
I have one question for the last speaker, Pastor Ayer, concerning the implantation of the cold tube. Frequently, after retractomy, some left vitreous is in the area of the tube, so it can become like a valve, opening and closing. Did you check by echography something of vitreous can plug the tube?
Yeah, so the retina team was very careful to do a very complete vitrectomy, and it was checked again that there was no vitreous left in the vitreous cavity.
One quick question for the paper on pellucid marginal with endothelial dystrophy. You mentioned quite correctly that the vision is very good despite high astigmatism. Do you know why that is in these patients?
Because the inferior displacement of the KMX, I think.
No, because they have very regular against the rule astigmatism. It's absolutely regular, and it is at 90 degrees to each other, and the flat axis is vertical and the horizontal axis is, so they have with the rule but very regular, and that's why spectacle vision improves the vision very good. And they maintain, and then you mentioned that because that was the case, you decided to do the procedure you did, but I didn't understand why you did the lens extraction with the toric implant when the vision, what you said, was have been good with the spectacles anyway. And the key point is when you put a toric lens implant in the eye, you cannot give the patient a contact lens afterwards. And what you said, this patient didn't want a contact lens because you would completely neutralize the astigmatism. So that wasn't even an option.
Yeah, he didn't mention that he didn't want the RGP lens before the intervention. So,
but he said he didn't want it after as well.
Yeah.
He couldn't have it after.
Yeah.
But when I need to get a toric implant in patient with graft of very severe corneal alteration, I prefer to put a head-on the horn, one spherical in the back and the head-on over, because in case I have to replace the graft,
yeah,
I can remove.
Absolutely, if you use a sulcoflex lens, which is what I tend to use in the rare cases I've done it, you have a piggyback lens for the astigmatism and a monofocal for the absolutely right.
The cleft that you showed on the anterior segment, OCT, could it be possibly that the patient underwent an intracorneal ring procedure before where the ring was removed?
No, there's no history of that. No.
Okay, because that would make sense, kind of, the size and the depth of the cleft looks very similar to where you would place an intracorneal ring segment.
Just a question, Jenny, for penetrating keratoplasty in aphakic eyes, do you use slightly larger graft than normal, particularly if they have glaucoma? And normally we would, it's not for you because it's not your favorite, but when you do a PK in an aphakic eye, we normally 0.25 oversize the graft.
Yeah.
But in aphakia, do you do 0.5 oversize or still 0.25?
0.25.
0.25.
Yes.
One last quick comment of this. We were one of the papers that reported this in families. Folks went with PK years and years ago. But the interesting thing in the families that we reported, we only had one member that had both keratoconus and Fuchs dystrophy. But within the family, there was a line of Fuchs dystrophy and a line of keratoconus among the family. So I thought that was interesting.
Concerning your question about how oversized, I look at the anterior chamber depth before to understand what is convenient to increase the anterior chamber depth or not, because that should be the key point.
Yeah, I mean, these are aphakic eyes where the chamber is usually deep, but what they say is that you can open up the angle a bit more by oversizing. I'm not sure that works or not, but just want to know what other people's thoughts were on it.
I typically go half a millimeter, and for my 8 phakics, I go 0.75.
So there you go, we've got one answer there. They do oversize more than you would normally do for a phakic.
Just a few points on the focal stromal degeneration with cross-linking. I'm sure some of, I did a presentation at the World Cornea Congress where I reported 6 cases, and it's not surprising that worldwide people are seeing these cases because it typically happens with the Dresden protocol and after a period of 10 to 12 years. And surprisingly, they don't have any epithelial problem. The epithelium is still intact. You have a focal stromal defect which gets filled with the epithelium, and because some epithelial cells get buried, you get that typically, you see those epithelial nests. And my understanding for that is collagen has a turnover time of 8 to 10 years. So it's beyond a certain point of time. By doing the cross-linking, you have killed the reproductive or the regenerative capacity of the collagen. So you have paradoxical, your cornea is getting thinner. You get corneas which are very thin, but the corneas become very flat. These are cases where the corneas have progressive flattening, so the keratometry can go up to 28, 29 diopters. And besides doing a surgical intervention, you don't have any other way of recovering from that. The second case where they were just observing will meet the same fate as the first case over the next 4 or 5 years, because that dead collagen is not regenerating, so it's not able to, and you don't get progressive ectasia despite the cornea becoming thinner. So I think that's why the newer protocols may prevent this from happening, but all the Dresden protocols that have been done, maybe we have over-treated, and in the long run, this is the consequence of that.
Any comment on the sensation of the cornea? And
sensation is like once you do cross-linking, the sensation reduces.
No, but it recovers normally. But in these cases,
we say it recovers, but still if you check, but they don't have any epithelial problem. In these cases, at times patients have been treated as an infection because that crater that gets filled by the hypertrophic epithelium, sometimes that epithelium falls off. And it has a very sharp defined margin, and the primary ophthalmologist looks at it, thinks that there is an infection and it's likely to perforate, so they aggressively treat with antibiotics. But when they come back to you, do the OCT, you get exactly the same reproducible image of seeing that crater-like defect in the stroma. And in fact, the paper by George Kimurian, where he has reported progressive flattening after cross-linking, this is published somewhere in 2015. If you look at the anterior segment OCT maps in his paper, it shows exactly that same crater-like defect. So the disease has been there, but we have not recognized.
I'm not familiar with the literature on this, but has anybody done histological, particularly immunohistological changes of the tissue they remove when they do down in these patients? Because that will give us a lot of information, particularly on the collagen expression and the types of collagen and the fibrotic protein expression in the corneas.
So, next speaker. Neuritis following corneal infection with methicillin resistant Staphylococcus aureus area gale.
Hello. Hello everyone, I'm Aaron Delord, and I'm honored to be presenting the ulcer with the hidden agenda. We have no financial disclosures, and our case starts with a 67-year-old male with severe pain and photophobia in the left eye. He had no relevant past medical histories. However, his past ocular history included cataract surgery in both eyes, as well as recurrent corneal erosions in the left eye. He presented with 2150 vision, with signs of redness, discharge, and an infiltrate. We diagnosed him with a corneal ulcer in the setting of recurrent corneal erosion. We cultured him and started him on vancomycin and tobramycin hourly. 3 days later, he was looking much better. So, and the culture came back positive for MRSA, so we continued vancomycin and discontinued tobramycin. 7 days later, he came back looking worse. A large KAD had formed, but the infiltrate was gone. We worried this was due to toxicity, so we reduced the frequency of vancomycin. And 2 weeks later, he was looking much better. The KEV had healed, and there was just a little bit of central haze. So we swapped antibiotics and started steroids. In the follow-up, he was looking much better, so we continued the management. However, 3 days later, he came back reporting worsening of vision in the left eye, but the cornea wasn't changed. But we saw he had a new optic nerve edema, and we confirmed this by OCT, and his macula was flat but thick. And then 3 weeks later, he came in with both optic nerve and macular edema. And on visual field testing, he had scatter defects. Now, this looks a lot like neuroretinitis, but it's odd because there's no macular star. And it turns out you don't actually need one. In a case study of 7 patients, all with Bartonella infection, in which they all have optic edema, only 4 of the 7 had a macular star present. So what is causing the findings in our patient? Is it something infectious, autoimmune, or something else entirely? We tested for infections and other etiologies. We did a brain MRI with and without contrast, and we studied topical steroids. But the workup was negative. So can staph aureus be the culprit? Is this staph aureus associated neuroretinitis? And if so, how? Well, we have 2 hypotheses. One is that the toxin created by staph aureus somehow made its way to the optic nerve and caused inflammation, and the other is a form of molecular mimicry. So we're here today to ask if any of you have seen this in your clinic. But fortunately for us, the patient came in 3 months later, looking much better, and the optic nerve and macular edema were resolved. And he has now remained stable for 12 years, with no recurrence of optic nerve or macular edema. Thank you.
Dr. Luz.
Hi. We present to you a case of ortho-K lenses related keratitis in a 16-year-old female who presented to us with acute pain and photophobia, which started 4 days ago. On clinical exam, we see a faint, subtle pseudodendritic lesion right there, visible also on the anterior segment OCT. Given the acute pain, the contact lens related this faint lesion, our presumptive diagnosis was of acanthamoeba keratitis. We then proceeded to do in vivo confocal microscopy, and you can see in these sections, which correspond by morphology to the wing cell layer epithelium, some hyperreflective round bodies which resemble the cysts of acanthamoeba. Out of 11 sections which we could obtain, only 2 bodies presented some morphological pathognomonic signs, such as a hyperreflective halo or a target-like ring, which you can see also here in the photos. These hyperreflective bodies are usually, they can be seen as neutrophils or polymorphonuclears, and this is our main concern every time we do in vivo confocal microscopy in a keratitis. Is this a cyst or could this be a polymorphonuclear? So usually polymorphonuclears or neutrophils are more irregularly shaped, but the cyst, which you can see zoomed out there, is a really round, sharply demarked body. So then we did corneal scraping, but another challenge for us was that we don't have a specific medium for amoeba in our service, so we had to find a solution to transport the epithelium to the microbiology lab, which was external. So we scraped the cornea, we placed the epithelium in a sterile saline solution and sent it along with the lens case to the lab, which was cultivated in a non-nutrient agar with E. coli overlay. This is a specific medium which acts as a feeding medium for the trophozoids. They advance using their acanthopods to get to the E. coli, and you can see in the video there 2 trophozoids along with 1 cyst due to our microbiology lab The other challenge for us was that in Romania we only have one anti-amoebic therapy, which is chlorhexidine. So we have only that, along with the study on azoles, more specifically voriconazole, which we could use in this case. So we started the treatment, and every week the patient was worse and worse. And then there was some associated stromal involvement, some subepithelial haze, visible also on anterior segment OCT. By external sources, the patient procured some hexamidine, which we added to the treatment on week 4. But the disease advanced until there was a focal stromal involvement, a unique zone which you could see on the anterior segment OCT here. So we decided to take the patient to the OR. At this moment, we start with alcohol-assisted epithelial debridement, 20% alcohol. You can see here, before and after the delamination, that the focal zone of stromal involvement can be seen. So then we, using the guarded diamond knife, we mark the excision margins, and using a crescent knife, we do the lamellar dissection. Following that, we continue the chlorhexidine along with hexamidine, and our patient comes back with a quiet eye and remains stable for like 7 months. Now, you can see the excision margins here on the clinical exam and on anterior segment OCT. Here is the topography 1 month later. The price paid was the irregular astigmatism, but it's a small price paid.
Dr. Morello? Yes, thank you. Thank you, organizers, for having accepted my presentation, which is about the endothelial resilience in iatrogenic trauma. The next, maybe some of you or most of you are corneal surgeons, but also cataract surgeons, and you know that one of the possible complications of the cataract surgery is the descemet membrane detachment. It can happen by endothelial touch at any moment of the surgery, at any place or any site, but most frequent, and I would say most stupid, it happens at the end during the hydration of the incisions. Like you see in this case, I was at the end of the surgery when I hydrated the paracentesis. You saw that horizontal line which led me to the present diagnosis of DMD. And indeed, the intraoperative OCT confirmed my presumption. I quickly injected air in the artery chamber, a little bit hypertonic, and the things went very well beginning with the next day because it was a normal eye with a normal endothelial cell count. What about this complication when you are dealing with an eye with corneal transplant, like in this following case, which is a lady which had 20 years ago penetrating keratoplasty in another clinic, and now she came to us with advanced cataract and with aspect of the OCT as you see in the picture, and a low endothelial cell count as presented here. So I took all the possible precautions to take care of this weak endothelium. I offered her flex, frontal laser assisted cataract surgery. I used viscose, dispersive and cohesive OVD in order to protect the cornea. I used a quick chop technique, and at the end of the surgery I had quite a low CDA, as you see in the upper right corner of the slide, which is only 168. So I was quite happy with my surgery. I said, okay, this cornea will survive. I implanted again under OVD, of course, the toric IOL. Everything was fine. I was quite happy. I was quite optimistic. And of course, at the end, I hydrate the incisions, which usually tends to be difficult hydrated in patients with corneal transplant, but I did it very well in the lateral paracentesis. And now when I wanted to hydrate, oops, look what happened when I wanted to hydrate the main incision. I saw a circular line going very quickly towards the opposite side, towards the 6 o'clock position, and it was descemet membrane detachment, highlighted here by the red arrow, and now you can see highlighted the capsular axis. Of course, my presumption was confirmed by the intraoperative OCT, And what I needed to do is to inject as soon as possible air, to inject more and more. It was several times I attempted to inject air, and under intraoperative OCT, the lamella didn't reattach, but I didn't have any choice. I just let air pressurize in the great chamber and sutured the incisions. Meanwhile, as you saw, a bit of blood entered from the incision, from the limbal incision, entered between the two layers, but I didn't want to wash it because I didn't want to enlarge the detachment. I just left it there. What happened, if you see again, the preoperative OCT, you see that it was highlighted by the yellow arrow. It was uneven surface of the anterior inferior face of the cornea, exactly at the limit of the host graft junction. And stupid thing to do, I did the main incision very close to that place, and when I injected the air, like the red arrow shows, when I injected the BSS, the damage happened. So let's see. The first postoperative days I was not optimistic at all. The cornea was hazy, the graft was edematous. I had some corneal folds, not that thick, not that visible, but 2 or 3 folds were filled with blood, which entered from the incisions. I was not happy at all. But 2 weeks post-op, the cornea started to be clear, and we can see more definitely the lines filled with blood of the cement folds, but on the OCT everything looked fine. 1 month post-op and 3 months post-op, again the cornea became more and more clear, and the lines filled with blood became thinner and thinner. Thus, 1 year post-op, we had a clear cornea and with an excellent corrected visual acuity, and the specular microscopy didn't look that bad as I expected. We have some take-home messages. In cases of cataract surgery, in the presence of penetrating keratoplasty, you can have uneven thickness and discontinued surface at the host graft junction. So that's why you need to consider a proper placement of the limbal incision, but before the surgery. And you need to be careful to manipulate the instruments and careful hydrate the incisions at the end of the surgery. And you need to recognize the DMD as soon as possible, I would say instantly, and once you recognize it, treat it immediately. Inject air in the anterior chamber from the opposite side of the DMD starting point, thus its enlargement is avoided, and leave pressurized eye in the anterior chamber. Some surgeons prefer expandable gauze, I use air, only air. And observe closely the patient post-operatively, both clinical and in terms of OCT. As a conclusion, the cornea and its endothelium turned to be very resilient after accidental descent membrane detachment during the standard cataract surgery. And it can be recovered completely, even in delicate PK eyes, if this complication is early recognized and if it is properly managed. Thank you.
Dr. Jossa, peripheral ulcerative keratitis.
Hello, distinguished colleagues, it's an honor for me to be here presenting my clinical case in such an amazing session with so challenging cases. We as a corneal surgeons, I like to think of ourselves that we can control any disease that occurs in cornea, but sometimes cornea is not the problem, it's merely a messenger. Peripheral ulcerative keratitis can be the first manifestation of a life-threatening vasculitis. It's important the early recognition of that in that case because autoimmune disease like rheumatoid arthritis or granulomatosis with cholangitis can be present up to the 50% of these cases. And there is a high mortality rate if the general disease is not under control. Let me introduce you a clinical case. It's a woman, 60 years old. I have been attending her for the last 5 years. She has a long-standing allergic conjunctivitis with subtarsal fibrosis, like you can see in the upper image. She has a type 4 allergies for potassium dichromate and cobalt chloride, which are present in so many domestic products. She has a severe non-showing hyposecretory dry eye, and I refer her every year to the rheumatologist, but all tests, the biopsy of the salivary glands were negative, and I treat her like guidelines recommend. I have to say that this case is standing me out because she always complains and she always has her red eyes. She have never had any ulcer, any corneal ulcer, but she had punctata keratitis. And one day, without any trauma, without any history of infection, she came with a spontaneous corneal perforation. I referred her to the hospital because I couldn't be there, and I hope, yes, they are right. And in the hospital, she underwent a penetrant keratoplasty, which it was a wrong decision, I will tell you why. Because they didn't take the consideration of her medical history of a long-standing dry eye and green allergy. And 2 weeks, after this first surgery, she was referred to me because a brand new corneal perforation affecting not only the donor cornea but also the receptor, the host cornea. And if I would have done only the corneal surgery in an inflamed bed, it's like building a castle on flowing lava, it would bend. So I scheduled a dual protocol. I referred her immediately to the rheumatologist, and in this time she was diagnosed by Sjögren's syndrome and also Cianca positive, so she had a granulomatosis with cholangitis. So she was treated immediately with a high dose of steroids and rituximab and CD20 monoclonal antibody. And myself, what I did was a tectonic surgery with an eccentric duct that you can see there, affecting the cornea and also the sclera, and amniotic membrane transplantation. You have seen below in the bottom part other surgical techniques that we can manage depending on the perforation, where is the location of the sites. If we look at the evolution, we see the changes from the active melt to ocular surface calm and quiet. And why is this possible? This is possible because there is an absolute synchronization between the rheumatologist and the ophthalmologist, and she's treated with rituximab and hydroxychloroquine, and I treat her with the topical treatment controlling the local inflammation. What are the take-home messages? The take-home message here is the golden rule of ocular rheumatology. Surgery must be delayed until adequate clinical and systemic immunosuppression is achieved. Of course, there are exceptions. If there is an imminent or a real perforation, of course, we have to do the surgery immediately. But let this case show us the main or the three pillars of the treatment. First of all, is that the peripheral ulcerative keratitis can be the first manifestation of a life-threatening vasculitis, like in this case. The second one is as ocular surgeons, as ocular surface surgeons, we have to tailor the technique rescue depending on the size and the position, the location of the corneal perforation. And the third, and the more important, the core of the treatment is the absolute synchronization between the rheumatologist and the ophthalmologist. Let me do a comparison because now it's running the Football World Cup. I don't know the rheumatologist of the ophthalmologist who is the goalkeeper, who is the striker, but both are essential to win the match. So thank you very much for your attention.
Now, Dr. Buzzonetti, luckily there is genetics.
Good morning. This is the case of a male, 26 years old, that was sent to me for penetrating keratoplasty with a previous diagnosis of keratoconus when he was 19, with a progressive visual decrease, no inheritance. This patient presented at the slide lamp examination a diffuse endothelial opacity in both eyes. In the right eye, visual acuity was 0.3, in the left eye 0.1. Shunt from camera and OCT anterior segment examinations showed an ectasia worst in the left eye. I performed a penetrating keratoplasty with a good outcome achieved in 12 months, but my opinion was that this patient was not really affected by keratoconus. mainly because of the presence of endothelial dystrophy. So with my colleagues, I tried to perform a differential diagnosis, and we ruled out endothelial dystrophy because of late onset, as well as congenital hereditary endothelial dystrophy, X-linked corneal dystrophy, because early onset. So our clinical suspicion was for a posterior polymorphous corneal dystrophy. Few months after arrived the child of this male, 6 months, with a previous diagnosis of bilateral congenital glaucoma. He was sent to me. We performed an examination under general anesthesia, but the clinical feature did not correspond to a diagnosis of bilateral glaucoma. No ophthalmos, but all parameters appeared as normal, except for the pachymetry about of 1,000 microns. So my clinical suspicion was for a check. So father, 26 years old, symptoms onset when he was more than 19, endothelial opacity, corneal ectasia. Child, 6 months, symptoms onset at birth, corneal edema. The clinical suspicious of posterior polymorphic corneal dystrophy that usually occurs in the first decade of life and is often asymptomatic with a characteristic endothelial features. CHED, we know there are two types of CHED. Type 1 that starts with in the first few years, presenting with progressive stromal opacity, and type 2 autosomal recessive disease that presents with stromal opacity at birth. So finally, both patients underwent a genetic testing, and for both, the diagnosis was of posterior polymorphic corneal dystrophy. It has been suggested that CHED type 1 is a type of posterior polymorphic corneal dystrophy with an early onset and corneal decompensation. The international classification of corneal dystrophy defines 4 different categories. Type 1, well defined with a mutated gene identified. Type 2, well defined with a mapped locus. Type 3, well defined without a gene or locus identified. Type 4, a suspicious without a no clinical, clear, defined features. Always our approach is oriented, in case of corneal dystrophy, towards a surgical management. So many patients do not get offer molecular genetic testing. But I suppose that all patients with a suspected corneal dystrophy should undergo genetic testing because clinical description alone often is not sufficient. And the genetic testing need, in order to achieve a precise diagnosis, in order to learn pathogenetic mechanism, and also in order to take advantage in case of new therapeutic approaches that have to correspond to a precise diagnosis. Thank you.
Well, we have a dilemma in that we have to give the result immediately after the meeting. So we have to calculate all the numbers while we are going on with the meeting. So that's why the judges will be fidgeting about. So I had one question for, the paper on neuroretinitis. Did you actually do any electrophysiology on this patient to look at the nerve function and conduction studies?
I believe that question is better suited for Dr. Carter.
It's okay, well, let me bring the mic to you. Oh, you got one there.
No, we didn't. It was a clinical diagnosis done by the OCT. Looked like neuroretinitis, and then it resolved on its own. So this is just an interesting case where perhaps the infection led to the neuroretinitis.
Yeah. Thank you. And this is a point about, alcohol delamination for acanthamoeba keratitis, a different paper. That was a very important message is when you see epithelial acanthamoeba lesions, you take them off ASAP. The only thing you did, you waited for a small stromal infiltrate to occur. You very correctly took that out. You got a good outcome. But if you did the epithelial removal before that, you get a very good cure rate. And people debride it physically, like they used to do in the early days, even for herpetic eye disease. And nowadays, for any kind of epitheliopathy, even if it is non-infectious, we find, and we published a couple of papers on it, alcohol delamination brings out the whole sheet intact. Physical debridement, you get it in clumps, and you can't do histopathology. But if you take it all out, it's a very good message over there. Early alcohol delamination. Any?
On the corneal endothelium, I think in your the tips that you gave at the end, I think it would have been helpful to mention that don't hydrate your wounds if you're doing surgery, either post-DALC or post-PKP. Doing a stromal hydration increases the risk of DM detachment. So I think best thing is to suture your wounds, and you can take them off in the early post-operative period. And remember that whenever you do a cataract surgery in these cases, your wound construction is not as good as what you would get in virgin eyes. So there may be a small DM detachment at the edge of your wound. So leaving behind a small, mid-sized air bubble in the anterior chamber is often helpful, especially if your wound is superior, because as the patient sits up, this small detachment can be addressed by that small, mid-sized air bubble.
Yeah, I was going to say the same thing. I always suture my PKs, especially.
Learn
The
the
etiology often is either severe keratoconus or some sort of corneal thinning after injury or infection. The other thing, of course, you can do is, which we've abandoned, is a scleral tunnel if you're really worried about a very thin peripheral cornea. There's absolutely nothing wrong with that as well.
And in those cases, I usually try to do a scleral entry because it impacts less on the astigmatism. If there is a good relative astigmatism, I try not to change so much.
Anterior segment OCT is helpful in such eyes to plan your incision. So you can do an ASOCT look at and then plan which area is the best for you, rather than going back to your usual site where you do that may not be the most appropriate site.
Whether it's post-PK or post-DALC, cataract operation, my experience from many cases is that avoid your cataract incision getting into the graft. So usually you find that you have more clear cornea temporally, so do a temporal incision because the distance or the width of the clear cornea on the temporals has much more than superiorly. And if you want to go superior, then as Professor Vincenzo just said, do a sclerocorneal tunnel, but avoid your entry into the cornea through the graft. And another very important point is, and the interesting point is that when you do a PK, you have cut the desmoids completely. Now you put a new graft, and when you get a detachment, it should not really occur in the host at all, because they're two separate desmoid membranes. They do heal well, but if one detaches, it will just rip off the edge of where the graft was in a PK. In this case, you find it was only in the graft, and the host desmoid membrane, which is separate, although they would heal, but there's always that weak adhesion between them on the circumference. So direct your cannula laterally, and as though you're hydrating the wound tangentially, not vertically or not directing towards the cornea. And I don't suture them. I always hydrate, but I've never had this problem. my resident had another bigger problem, which was the cannula ejection through and massive damage, which is another serious complication of hydration, but should avoid with the dual oxygen.
I have one more question for Ariel. You're supposing that the MRSA organism was the potential cause for the neuroretinitis. Has there been any, this is my naivete, is there any literature that could implicate the antibiotics, the vancomycin or others, as a potential cause?
I think that's also better suited for Dr. Carr. I think that's better suited for Dr. Carr.
Thank you for the question. It's a great point, and there's no direct evidence that I could have done. But this opened the door, and you ponder how many of the corneal ulcers that we have. We never look carefully back to the back part of the eye. So you wonder other toxins or effects of antibiotics may have effects in the retina and the optic nerve as well. So I think this raises a very good point about how we continue to look better at the posterior segment of this infection. We focus on the cornea and forget about the optic nerve.
Nowadays, more and more we're looking at the macula because
Absolutely.
the cystoid macular edema after your lamellar grafts has become so common. And medical legally, it's good to do an OCT even before you do the operation. And you can say, look, there was some problem before, and you can also counsel the patient accordingly. But we are, as cornea surgeons, become more conscious of the retina, particularly the macula.
Yeah, absolutely. So your question about optic nerve function, yeah, in this case they were not done, but that may be a very excellent plan as we move forward in all of these cases. Thank you.
Go to the next presenter. So please, late onset hospital is not important in Boston Proud type 1 implantation. Dr. Bazak.
Good afternoon, everyone. So it is just opposite to normal complication of Boston-Kepro type 1. So I'll be presenting late onset spontaneous chronic hypertonic in a long series. This is not a case report. Forward is next, okay. So, how do you define ocular hypertrophy in Boston-Kepro 1? When in 2 consecutive visits the IOP is lower, we always palpate by finger. It may happen for many reasons in early and late post-op period, and those are obvious causes. There are anatomical causes. But this cause, without any anatomic or overfiltration problem, it usually appears few months or years after Kepro implantation. My first experience in 2016, this patient was operated in 2009. After 7 years, he presented with low IOP with choroidal folds. So we stopped all AGMs and given subtenon, triamcinolone. And his IOP was lower side for 1 year, choroidal fold increases. Then VR intervention was done with pars-planar vitrectomy and heavy silicone oil injection, 5000 CST. IOP normal side, visual acuity improved, and he lost after COVID. This was my second case with no valve, doing fine for 2 years. And this was the photo in February 19. And in 21, he presented with severe hypertony. And this time we could take the fundus photograph and you see the choroidal folds. It's very difficult to capture all times photograph because of RPM is there. So recurrent RPA, macular OCT, optos, you see there are choroidal folds, but not very clear. But again, this patient, we straightly underwent VR intervention with heavy silicone oil, and the patient recovered well. This is in the lower photograph, the before, and upper photograph is after silicone oil injection. This is, the recurrence is still going on, and the the RPM increases, and after that membranectomy, he was maintained 460 lesion with, you see a lot of silicon bubbles are there. This is third case. I do not have fundus photograph. You see that serials of RPM in this patient. And this patient developed hypotony. This is the fourth case, and we could capture the ultrasound. You see the choroidal folds are there. And after third EAC membranectomy, you see that the improved after STT, and we usually give difluran eye drops in these cases. So we analyzed our series over a period of more than 17 years, and you see that out of 118 eyes we analyzed, some of them are excluded because of obvious anatomical abnormality. And we have analyzed our data, and we have tabulated all the demographics, we have post-op details, the clinical courses of the RPM and its management. And then the results comes out like that. Incidence of hypotony is 10.2%. Mean pre-op IOP was normal. Mean follow-up period since K-Pro surgery is 40 to 130 months. Mean development of hypotony is around 40 months. Treatment given is stepwise, laser surgical treatment of RPM, then medical therapy, then partial vitrectomy if required is heavy silicone oil. Medical therapy consists of withdrawal of AGMs, systemic isolon, topical difluprednol, 2 to 3 or maybe 4 injection of subtenon triamcinolone at 6 to 8 weeks interval, and surgical treatment, 6 eyes required partial vitrectomy with heavy silicone oil, and 2 eyes didn't respond with treatment and gradually goes to thicycle. Regression analysis showed that the increased risk of hypotony with eyes of recurrent RPM, it is highest. There is no such risk with AGV, with multiple failed grafts, with backplate size or backplate material, or the PMMA or titanium. So we could perform UVM in 5 of these patients. It was very difficult in these cases. And it showed that there was diffuse ciliary body atrophy, detachment, thinning in multiple quadrant, and suprachoroidal effusion in some of the areas. The probable mechanism of inflammatory, ischemic insult, fractional detachment, ciliary body atrophy, and gradual aqueous production reduction and chronic hypotony. So we investigate, then treat medically, and BR intervention if they are not repeated. There was one only published series in 14 years back that was from ACPEC series, and they have reported that their incidence is 9%, and they have suggested that PP vitrectomy with silicone oil, they have do the same kind of result with, they could do enucleation in 2 cases, and they have shown the histopathological and the same type of. So here the question is that why this hypotony is happening, that RPM and its management, how do we manage it, that is very important. Medical treatment, sometimes helpful, surgery is also required, and sometimes you may lose these eyes. So late onset spontaneous chronic hypotony is an important late postoperative complication of Boston K-Pro 1. Its visual and structural consequences warrant early recognition and aggressive treatment. Some RPM are not benign, especially with recurrences, need vigilant follow-up to avoid grave prognosis. These 2 are 6 and 8 are 2 interesting references. If someone is interested, they can go through all this. Thank you very much for your patience here.
Dr. Fordini, smart solution for a tragic complication.
Good morning. Thank you for the invitation. I just present you actually a simple case, a very common situation. It is no special surgical technique at all, but I just want to present you this because it can happen actually in our real ordinary life in the hospital or in the office. So this is the story of this patient. 8 years old patient came to our clinic in a hospital in San Marino. Actually, this story is 3 years ago, it was 2023. So now it's 3 years of follow-up. So now I finally can present you after the end, the happy ending. But at the time, came to our hospital. Why? We have to go back. When he came, he told us that 7 years before he had a retinal detachment with vitreous hemorrhage, treated at that time with phaco-iol, vitrectomy, and silicone oil tamponade. Okay. Then later, silicone oil was removed and some emulsions was removed, but it was again retinal detachment with new tamponade with silicone oil. But what is more interesting today? That 3 months before coming to our hospital, he told that he had IOL exchange because of IOL opacification. That was in another clinic, so he told us that he had this IOL exchange, and the surgeon in the other clinic removed the opacified IOL and he put in a new IOL scleral fixation. But the most important thing is that he had to open the cornea, very large opening, about 6 millimeters in the superior sector. So that surgeon did a very good surgery. He removed the old opacified IOL, 6 millimeters opening, and implanted the new scleral fixation IOL. This is the IOLs. But 2 days before coming to us, the cornea suture was removed in office, of course. So what happened? The patient came to our hospital in a tragedy with corneal diastasis, because probably, we don't know why. Maybe he was rubbing the eye, or maybe it was not a sufficient scar, but the entire corneal opening was opened again. So can you imagine? Tragedy situation. So this was the situation when he came to us. Of course, he noticed sudden vision loss. The eye was super soft. There was collapse of the anterior chamber, so of course very shallow anterior chamber, iris incarceration in the superior corneal opening. The IOL was tilted, as you can see in the picture, was tilted, and a very severe hypotonia with choroidal detachment. This is the photo of the fundus of choroidal detachment. So, of course, it was a dramatic situation. The only good point I have to mention is that iris tissue was not prolapsed outside the eye. Everything was in the eye, but very soft and opened. So, this was, we took some picture in that time in the anterior segment OCT. You can see the situation. You see in the picture the iris touching the corneal wound, but fortunately not going out the corneal wound. So anterior chamber was very straight, and the IOL was very tilted. Okay, this was the situation. And in OCT macula, we had choroidal folds, of course, because it was very severe hypotonia. So actually, this is a practical comment. It was night, and of course I wanted to go to operating room, but the operating room was busy with major surgeries, and so we had to wait for the following morning because no immediate availability of the operating room. So in that time, I just put a contact lens and a patch. That's it. Try with my contact lens to stop a little bit and avoid infection, whatever, and wait for the following morning. But the following morning, we had a very nice surprise, very happy surprise, because actually when the patient came back the following morning, I removed the patch and I saw this. So I was like, wow, well, not so bad. Well, so maybe we don't have to go to operating room because actually anterior chamber was restored, IOP was raised to 14 millimeters, was good. IOL was recentered and no signs of infection, most important. This was anterior segment OCT the day after, much better. The anterior chamber was good. The IUL was almost good, but okay, it was there, and no sign of infection. And OCT macula also reduced choroidal folds, still present, but much better. So we didn't go to operating room. And I followed the patient the day after, the week after, almost 2-3 days, and better and better and better. So 1 month after was fantastic. Complete restoration of the chamber, IOP was perfect, IUL in place, and no surgery needed. So this was after 1 month. Again, the OCT anterior segment was good. The IUL was a little tilted, but okay, the vision was quite good, so we didn't want to operate for that. And macular choroidal folds was much better. So I don't want to say that we don't have to go to operating room, of course, but maybe it can happen. So we just remember that sometimes contact lens can be very helpful, and it's a tool. But we were lucky; it was like a miracle, probably. But sometimes we can. I think that somebody of you already had the same experience, but just to remember that. Thank you for your attention.
Now the last presentation, Dr. Lavja. How to avoid dark.
Thank you for the invitation. So I want to share my experience on practical cares, and especially in the civic case. So this is a case report of a young woman, 20 years old, with intellectual disability. I saw this woman in 2020 for a keratoconus, and the first plan to put a pin and a ring, and after that a cross-linking. But I lost the patient 5 years. And we see on the topography, we are on the civic case of keratoconus with a poor vision, paracentral stromal opacity, and the camat very high. On the right eye, we have a keratoconus with a less advanced. So here is the progression of the keratoconus between the first consultation and the last one. And we see that the progression is very severe because she rubbed her eye. And here, just before the surgery, the planned surgery, this is the topography of the both eyes, with on the right side a dark phenotype, and on the left eye severe nipple phenotype. Have a look on the pachymetry on the left eye, 470. I will explain why after. On the family history, I operated on her mother 3 years ago, and I've done the PKP for stromal scar in the middle area. The post-operative course was complicated by pain, cataract because of a long treatment steroid, and the residual astigmatism. Because of pain, I operated on by cares 1 year after in the both eyes, on the left to treat the last astigmatism, and on the left eye for normal keratoconus. So, according her daughter, I've planned a dark on the left eye because of severe case, and I planned the cares on the right eye. But her mother refused, because of her disability, she refused the dark because of pain, the long follow-up, and she asked me, because she was very happy on the result for cares, she asked me to perform the surgery by cares on the both eyes. So I reconsidered the surgical strategy, and to plan the surgery, I need the under OCT, and this is the picture of the left eye. You can see abnormality on the thickness between epithelium and stroma. And we know that CARES is a stromal treatment, so we have to take into account the thickness of the stroma. So in the place of the scar, I can put the CARES. So I have to decenter the treatment. And this is here my CARES safety requirements. I need 200 microns above the tunnel to avoid the extrusion, and I need more than 100 microns below the tunnel to avoid endothelial decomposition. So this is here my surgical technique. I implant annular 2 segments, very thick, 600, and I slide this concentration to avoid the scar area. This is only possible with the Z8 because we have an OCT guidance. We can avoid the complication. So this is 1 day post-op, corner is clear, and the implantation is close to the scar of the area, but not in the same place. This is the OCT, and this is the result. So I have the very fast recovery with 20, 40. I have a flattened effect of 30 diopters, only 1 month of treatment, and the patient was very happy, also the mother. The recent publication demonstrates the emergence of CARES as an alternative to DALC, but no data on the contribution of each surgery, but I think on the future we will have a decreased rate of DALC, even in severe keratoconus. So CARES may be considered as the first option even in advanced keratoconus because it's a mini-invasive procedure. DALC provides better outcome, but DALC is a still invasive procedure with unpredictable complications. Advanced keratoconus, as long as corner is clear in the pupil area, respecting pachymetry, I mean 300 microns, could be the first intention treatment for keratoconus. I invite you for a course for next September in ESRS with all my colleagues. We will have a longer discussion about the advantage of the femto CARES. Thank you.
Way we are deciding the work.
Yes, we'll have some discussion while I've handed over my mic, so my mark, sorry, not my mic. That's precious. Let's discuss some of these papers. So, Dr. Basak, you know, your index case, you mentioned that you had vitrectomy and silicone oil, and the vision improved. Now, when you put silicone oil and the refractive index of the oil, does it not neutralize the focusing power of the prosthesis that you've put in the cornea? Because we've seen that with the implants.
But we have to, for maintenance of IOP, we need to give heavy silicone oil. Otherwise, the eyeball is so soft by finger palpation. We know that with no time this eye will be tricycle. So we are forgetting about, we are thinking of only ambulatory vision in these cases.
No, I understand. I mean, what you mentioned, the vision actually improved.
Yeah,
636. I thought you would have lost the focusing.
With best correction, whatever correction they can afford it.
And temporary, now there is this paper out of Moorfields where they're using Helon, GV, to build pressure hypotenuse size. They're injecting viscoelastic into the eyeball instead of oil, and that may be temporary, but that is something you might consider.
That is for temporary, because these patients are in agony, because several surgeries, several intervention. So you want some solution that at least could go a few years.
Yeah.
So that's why we are thinking that our vitreoretinal surgery surgeons are very accustomed with heavy silicone oil, and they are doing well. Some, not all patients, some of them are doing well.
Yeah. So how do you differentiate the cause for hypotony being the underlying severe eye disease, which leads them to needing a keratoprosthesis, versus a post-operative complication of keratoprosthesis? Both of these as potential.
We know that the main causes of hypotony we know, starting from retinal detachment to wound leak to valve surgeries, there are overfiltration. We have excluded all this because these patients are for a long time of minimum of, say my first patient represented after 7 years. So this time the patients are doing well. Then naturally the follow-up periods every year. Initially every 3 months, then every year when we used to remove the contact lens.
True, but any surgery on these patients has that risk. Whether
the patient sudden loss of vision and they come then.
Did you see the hypotony in patients that did not have a retroprosthetic membrane?
All patients have retroprosthetic. All. That is the unique thing, and not single RPM. They are multiple RPMs. Fast RPM we used to do EAC, already just milder. But when the RPM is thicker, you cannot do EAC. Then you need to take help of EAC surgeon.
You have a question from the audience?
Yes. Yes.
Great talk, and also on similar topic. So we have noticed that in these keratoprosthesis patients, when we put silicone oil, almost every time we get these dense retroprosthesis membrane. In fact, some years ago we wrote an ARVO abstract on like 12 cases and never published the paper. But then, and as you said, they become thicker, we yag them, and then at some point we have to go with retractor. And then some of them develop this hypotony. So I always wondered, is it the cyclitic membrane, or is it what Dr. Rubinstein said, they are such sick eyes that yet another surgery just pushes them down? Have you done histopathology?
Histopathology, no, but the aspect paper in 2012, they could do enucleation in 2 patients, and there we have done UVM in some of the eyes because the patient, they do not agree for any kind of invasive investigation on this. So 5 of them agreed, and histopathology and these findings are almost similar. There are I have captured only one image, but if you see multiple images, then you could see that there are tractional element, whatever you are suggesting, maybe during pars plana membranectomy. The surgeons may pull because these are very tough membrane, not their ordinary membrane, what they do deal with. Not like epiretinal membrane or other kind of. These are very, very tough fibrous membrane.
Yes, they're like sclera sometimes.
Yes.
Anyhow, so thank you for the heroic saving of the 145.
I know, huge number of cases. Yes. Now, I have a question for Dr. Follini, that very interesting case, and I'm going to give you a clue as to my age. Because when I started doing cataract surgery, it was 1 Graphie knife, intracapsular extraction. We made an incision that was almost 180 degrees, maybe a little less, no sutures, and it healed. And the AC was formed. We didn't put implants in those days, but we left the patient aphakic. So the wound does heal, and the only thing that the bandage lens might have done in this case is preventing the lids from disturbing the position of the lid and not rubbing so much of the cornea, not rubbing so much on the cornea. But it does spontaneously heal even without a contact lens. In the intracapsular days, it used to happen. So a much bigger wound. So it's possible that, and many of them would also leak. So, but majority would be fine. And in your case, the question specifically is that the lens did not recenter. The pupil came down, and you can see that the the pupil is now covered with the optic behind it, but the decentration, if it was a suture lens, why would it decent in the first place unless one of the sutures broke, and then probably you would consider putting it back in place.
Thank you for a comment and question. Yes, actually, you're right, because one of the two sides of the suture was not holding. I had also, after many months, I had the idea to go back to the operating room to refixate the IOL. And it's true, actually this patient was 85 years old, and so many surgeries that the patient told us, it's okay. But actually the IOL was a little not in the good position. Yes.
And have one comment, perhaps, let me get the name. It's regarding the cares, yeah? So, and I have not done cares, so I'm asking you as a person who wants to know rather than challenging anything you're saying or questioning what you said. I have attended many meetings where people have said that over the long term, the cares implants resolve, they absorb, they change the thickness with consequent effect on the corneal curvature, and that we are sitting on a time bomb. With thousands of cares being done, in the long term we will find we'll have to revisit these corners. This was a comment somebody made, a very junior doctor who said, we are now dealing with the consequences of what you guys have done 10 years ago or whatever, that these cares patients are reversing. What is your experience on that? Do you think there is some validity in that statement?
I began this surgery just 4 years ago when I met Susan Jacob. I began the technique with manual technique, with the Trefine. It's fine, it works very well, but since 2 years ago I get the date, and it's customized treatment. I can't. Okay, it works very well. So let's say I have only 4 years of feedback, but when I saw my patient, everyone is very happy. But I learn each time I operate a patient with keratoconus with cares, I always changing my settings. The main message I want to send is to have good results and to keep stabilization on this kind of surgery. We have always to oversize the graft according to the tunnel. If you put a graft smaller than the tunnel, you will have edema in post-op, 1 month, 2 months, and after that it decreases the effect of the surgery. So it's important to understand that the graft should be oversized, and to make it, to introduce the graft in an easy way and inside the tunnel. It's also important to wait to dehydrate the graft, to insert it as an easy way.
Thank you for that. Anybody in the audience with experience in cares who would like to comment, or Rajesh?
Well, I've been doing it for past 2 years, and one thing, the difference between using a PMMA segment versus using an allogenic tissue is that the eye bank corneas, I prepare my own grafts, so usually the grafts are matters when you prepare them. So when you take the sizing and you go back and you insert them, sometimes you will find maybe a 10 to 20% reduction in the dimensions of the graft volume. So that's why what she was saying is that you oversize it, taking into account that this will thin down. But in the long run, it doesn't really progressively become thin, but it doesn't biointegrate with the cornea. So even a year or two later, if you want, you can pull them out.
And what do you say then when people are using desiccated expands? There you can't really anticipate the final thickness.
No, the desiccation, what we do is for the ease of insertion. So
yes.
We prepare the segments, Then we wait. Either we use thermal mechanisms where you use up to 40 to 50 degrees centigrade to try and rapidly dehydrate the graft, so it becomes thinner and it becomes rigid. So the manipulation becomes easier. You can just push it in just like a PMMA
It's
segment.
tailored, desiccated. It's not that you
Yes.
have a
No.
supply of desiccated grafts that you can use.
I don't think so, but iBanks give you like Vision Graft or Kera Natural, they give you, with the femtosecond laser, they cut out and they send you the segments like that, which you can then dehydrate and insert them.
Can be also cross-linking to make it.
Yeah, but my experience of cross-link, I do less and less of cross-linking. Because if you kill the collagen and you're putting in that collagen inside, I don't want to do that.
Just I want to add something. The most important thing also is the implantation of CARES is more superficial. That's why we can, the deposit of the PMM rings, we can implant it in 200, so it allows the implantation for CVKs.
Let me ask you, Professor Dua, what does cross-linking do to collagen? If you go and Google and if you see, human collagen naturally, as you grow older, your collagen gets cross-linked. And if you look at it, your cross-linking makes the collagen more brittle. It may be stiff, but it's brittle. So my biggest worry is that the more and more unregulated cross-linking that you do, and if these corneas are subjected to stress, the healing power of the collagen may not be as good as a normal eye. The patient were to develop an infection or something. That's why you see reports of cross-linking, and when they get an infection, it very rapidly progresses to melt and people have to do a cornea transplant. So I think cross-linking, the protocols have evolved. Now we do for a much shorter duration using higher energy, but definitely we are trying to preserve the normal collagen as much as possible.
I think also the big question here is not so much the collagen, but the cells that produce the collagen, because cross-linking does cause keratinocyte apoptosis, and the recovery may be different. Sometimes you get increased response, you get haze and scarring, sometimes you get no response. And what you find is that the turnover, collagen is a protein that turns over through life.
We published a paper recently on long-term huge flattening of those patients. We do confocal microscopy and we found out no cell at all. Then we have grafted two of them and we see completely decellularized. And we observe mainly the 3 milliwatt protocol and wide diameter. So we kill all the cells. So probably we have to have smaller millimeter diameter and lower.
And individual response will be different. Some patients recover and some here. So I think there are lots more things going on other than that.
So regarding collagen cross-linking, so we said, what are we doing? We are really killing the collagen. So it's interesting, in cornea we only think of ourselves, right? Cornea. Versus there's the whole aspect of glaucoma and intraocular pressure, and we are decreasing, as you said, the stress. We're decreasing the dampening of intraocular pressure in these patients. So what's going to happen 40 years from now in the 20-year-olds that we are making the cornea so stiff, some of them who were going to develop glaucoma? We have some papers about decreasing the dampening of intraocular pressure. Glaucoma has a lot more on that, but we have to think of the optic nerve too, since that was brought up earlier.
You think we should cross-link the lamina tuberosa? Right, so I think we're ready with the decision, and yeah. So it's my pleasure. We had a very, very interesting morning running into the afternoon, and we had some very good presentations. Some were cases, some were case series, and all of us marked, and unanimously our top 3 were the same. So that's a great thing. And then we had to go by the adding of the marks to differentiate between the top 3, and we've come up with the prize goes to the plaque therapy for CIN. Dr. Cohen.
Ma apriamo anche qua, secondo te? Robby?